Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. My name is Mohammed Al-Sayed. I'm one of the SAMS Education Committee members. I have been with the Education Committee for about 10 years now, and we have worked on a lot of workshops to help Syrian physicians and Syrian students to come to the United States for the U.S. residency. First of all, I would like to congratulate all of you for your big achievement. You have done a lot of work, and you spent tons of hours studying, preparing, and interviewing. And now you have made it. Now you are actually starting your first step in the healthcare system in the US. This is a big moment for you. All the hard work that you have done and all the long nights and long hours of studying and working with other people to achieve this moment now is going to start on July 1st. July 1st will be the first day for your residency, and this is really exciting. With the education committee, we would like to help you to be the best, and that's our goal. I would like to advise you to stay focused on your goals. Make sure you keep working on your achievements and always improve and not prove. You have now the time to shine during residency. So work on improving yourself, improve your knowledge, your skills, and your talent, and don't waste your time proving yourself. You already proved yourself as a well-rounded physician, someone who worked really hard to get to this position. So now this is the time to learn and also implement everything you learned before into action. I don't want to spend a lot of time talking about SAM's Education Committee, but you know about all the workshops and the projects that we have worked on in the last 15 years. And I would like to start this Residency Essentials Bootcamp for 2025. We will have 2 days. Day one, we will have two sessions. The first session, we will talk about understanding the U.S. residency system and expectations. And in session two, we will have clinical documentation and workflow efficiency. We will have in the first session, I would like to start with our first topic, which is Introduction to the U.S. Residency Training. This will be given by Dr. Majd Jazaerly. Dr. Majd Jazaerly, he's a dear friend to mine. He is one of the stars in the education committee. He worked tirelessly in a lot of projects with us in the education committee. He's a cardiologist, and he is currently an electrophysiology fellow at the University of Rochester. And if you can, Majid, you can start sharing your screen.
Yep, I send the request to share the screen. Good morning, guys.
Majid, you should be able to share your screen now.
All right, let's try. All right.
So, Said, if you can stop sharing your screen, please.
I gotta leave the Zoom and open it again. I don't know why, but it's gonna be shortly.
No problem. Maybe we can make Majid and all the speakers as co-hosts. That will make it easier for them.
Here we go. Can you guys see my screen?
Yes, we can. Yes.
All right.
Go ahead.
All right. Thank you, Muhammad, for this introduction. I don't deserve all of that. Good morning, guys, and congratulations. You've made it. All right. It's very unique feeling to be to match in the US residency. So enjoy it to the max. The hard work is gonna come soon. So try to enjoy your time for the last few weeks before you start your residency. My name is Majd Jazaerly. I'm currently the Chief Fellow at the University of Rochester for Electrophysiology, and we'll talk today about the introduction to US residency and training. I used to be Chief Residence and Chief Cardiology Fellow at University of Miami. So, all right. So again, congratulations, you've made it. July 1st is going to be soon. You've heard a lot about residency by now. Of course, you have a lot of friends. You did a bunch of interviews. You've heard a lot about residency, the intents of residency. How much are you going to learn through residency? The ups and downs during residency. So today we're going to talk a little bit about the practice guidance, how you transition from medical students mentality. Some of you have already done some residency, some training in different countries. Some of you not, just like out of medical school. So we'll cover the understanding of US medical system, the culture in the healthcare here, the communication strategies, the duty regulations, building professional relationship, and career development pathway. Most of you done residency, done some medical rotation here, but I know some people, they were not able to, and gladly they match into residency. So this is just like a brief introduction of who are the people that you are gonna deal with for the next 3 or 4 years, depends on your residency. Your attending physician, they have the ultimate responsibility for the patient. Everything is gonna be under their medical license, and they are your primary teacher and the primary evaluator. All of you, like all the rest, like all of you guys are gonna evaluate each other, but the main evaluation you're gonna get, it's from your attending. If you are in an institute that they have fellows, you're gonna interact a lot with your fellows. You're gonna learn a lot from them too. The residents, they're gonna be your new family. Your seniors, your juniors, and your colleagues in your intern year. Those are gonna be your new family. Try to have a great relationship with them. Try to learn from them and educate them. Some of the programs, they have medical students also, and like in the US system that we don't have at all in Syria. For people, they did some training back in Syria. You have like the PAs, the NPs, the pharmacists, the therapists, different kind of therapists, and the nurses. And it's very important to have strong professional relationship with all these people, especially the nurses. You gotta get the nurses on your side, otherwise you're screwed. All right, as we talked about a little bit before, the US medical system, it's not like Syria at all. Not even similar to any residency program outside of the States. It's unique, the system here, but it's strong and solid. Nurses are very powerful. So if you get them to your side, you win the lottery actually during residency. Patients here, they will ask a lot of questions, like a lot. And that's why the shared decision making, you need to understand your patients in and out. You need to understand why they are in the hospital. You need to educate them about that. And at the end of the day, you're gonna take the decision after you share the plan with share the decision with them. You're gonna come with one plan. And as I mentioned, you need to learn it's a shame actually if anyone knows your patients more than you. You should know the patient more than the patient themselves. Intern year, imagine if you like play shatranj, you are the bayad technically. You're the first line soldier. You're gonna have a lot of tasks, but remember, we've done it, you can do it too. You're gonna pre-round on your patients before the round. You're gonna do the notes. You're gonna put the orders. You're gonna follow up on the orders. You're gonna admit and discharge patients. You're gonna take calls with the pagers, and you're gonna have nights. Most learning usually happens during residency, either during night float or when you learn when you do some mistakes and you learn from that. Those are the most time that you will learn during residency. Cap per ACGME is 5 patients per night. So if you're doing 12-hour shifts for maximum of 5 patients you're admitting, technically you have more than 2 hours for every patient. You have 2 hours to like do the notes and put the orders, and the rest of the time you can learn about the condition, why the patient presented. You can read about it. That's why learning and education happen a lot during the night, especially if you have a good senior with you. You can ask them a question. They will you can have great discussion. You can both read at the same time during night. You are gonna feel overwhelmed now from this talk, from different talks, from when you talk to the people. You are gonna feel overwhelmed, but that's fine. That's normal. All of us, we've been through this, and we passed it. So you can pass it. Duty regulations, the physician-patient relationship, as I mentioned before, patients here, they ask a lot of questions. They want to be part of the decision-making. So you're going to share everything with the patients. You got to know the patient's autonomy, and you're going to know how to inform patient about consenting patients. And you have to be honest with the patient. You cannot lie. You cannot hide stuff from the patients. Whatever you feel that the condition, you're gonna mention, explain it in details. If there is a procedure, you're gonna I'm a cardiology, I'm EP fellow now. We do procedures all day long. When I go to the patient, consent them before the procedure, I will tell them that one of the risks is heart perforation. So they will get scared, but at the end of the day, I will tell them that we do this on a daily basis. So rarely this thing to happen, less than 1%. But at the end of the day, I don't hide stuff from them, because if I hide stuff from them, it's, first of all, it's immoral. Second thing, you will have big legal problem. But first, think about the humanity issue. It's immoral to hide stuff from the patient. The work culture, the workplace culture, punctuality is critical. I was a chief resident, and before that, when I was an intern, I remember that every single day, that was before COVID, every single day, I will arrive 30 minutes before the sign out. I'll have my tie, my shirt, I iron everything. I iron my white coat. I do my hair every single day. So that will build reputation for you gradually. And you gotta think also about the team-based approach. You are not alone. You're gonna be in a team. You guys are gonna share all the decisions. Questions. There is no silly question. Whenever I had a question, I used to ask. I will start, okay, probably I have a silly question, and all of them, they will tell you that there is no such a silly question. Especially in your first year, there is no such a silly question. Just ask question. But of course, ask them in appropriate time, not like when you're attending stalking when you guys are talking about different thing, jump straight back and ask question. Choose your right time to ask question. Work-life balance is very important. You are gonna work a lot of stuff, new stuff that you're gonna face. Make sure that you will have work-life balance. Your family, if you have a family, if you have hobbies, make sure that you do this on a daily basis. I play soccer, I play basketball. I keep playing soccer and basketball. Of course, not like as much as I played before residency, but I kept playing those religiously. I tried as much as I can to keep my hobbies and work on and do my hobbies. Professional boundaries, it's very important. Maintain appropriate relationship with every single one. In the first 6 months, you're not gonna have brotherhood with people around you. But after the building professional relationship, you can pick and choose who of the residents can be close to you. Make sure that you have professional relationship with your attendings. Of course, sense of humor, it's always good, but know your boundaries. Social media awareness, it's very important too, especially in our days now, especially with the situation like what's happening in the Middle East. We are part of that. Make sure that social media, your social, either isolate yourself, don't put any titles. That's the brief advice. Don't put any titles or relationship to your hospital on your social media, or if you put that, if you put your resident in this hospital, you're committed to their social media policy. So make sure you are aware of that and ask your chief residents in the beginning, like, is there any social media restrictions? What are the social media restrictions? It's very. I remember in my when I was second year, 16 of the residents on my 16 of the third year residents, they got on probation because they posted inappropriate picture on Facebook. All of them together, 16 of them, they got probation. So make sure that you know everything about the social media awareness and patient confidentiality, of course. Like, don't post stuff related to the patient, don't text. You're gonna have secure mobile apps to discuss patient relationship issues with the nurses, with the attendings, with another residents. Do not text or on like messages or WhatsApp. So HIPAA is very important, and you guys are gonna have a lot of HIPAA courses in the beginning of your training too. Quality improvement and patient safety. The most common electronic medical records, usually it's Epic, Cerner, Meditech. Those are your new best friend, not only friend. So learn them fast, okay? Because it's gonna save you a lot of time, okay? Essential skills. So one, like as we mentioned, your duties, you need to know how to put the orders, follow up on the orders on a timely manner. That's very important. If you're senior, if you're attending during round, ask you to put order, like, let's order some potassium for this patient, let's change the dose of the medication of this patient. Make sure you document that, because you are gonna forget. No one will remember everything. Document it, write it on a paper, on your list, write it on your phone. You are gonna forget it if you don't write it. Make sure to write it, follow up, do it, put it, and follow up on it on a timely manner. Like, I remember my attending asked me to change like the lisinopril dose, increase it from 5 to 10 or 20. I will put it, write it, put check mark. So when I'm done with round, I will go review my patients. First thing I review is the orders. Okay, all the orders. I will go patient by patient. Those 2 orders for this patient, I will open the patient, make sure that those orders are in the system now. Okay, I will put a check, move to the next patient. And after that, when you finish these, you gotta follow up on the orders. Did the nurse give the patient a new medication or not? Did the nurse give the potassium for this patient or not? You need to have a good relationship with the nurses. You need to ask the nurses to make sure that they follow up on your orders in a good way. Like, you don't have to ask them like you are ordering them something. Hey, did you do this? Did you do that? No, in a friendly manner. And by time, when you ask them in a professional way, keep it a professional, be nice to them. You're gonna build a strong relationship with you. Of course, same thing for the note, progress note, medication reconciliation when you admit and when you're discharging the patient. This is very critical and very important, the medication reconciliation. Sometimes you gotta take the phone and call the pharmacy if you're admitting a patient and you have a doubt about the medication, or if the patient had a refill like a few days ago. Okay, it means that this medication is legit. But like, one of the medication last refill was 6 months ago. When you ask the patient, do you take this? Are you still taking this medication? The patient probably, they don't know. They don't know every tiny details about their medication. They will tell you the blue pill, the pink pill. So you gotta make the phone call to the pharmacy. Make sure you have the most updated medication list. And based on that, when you discharge the patient, you discharge the patient on the appropriate medication. And of course, the discharge planning, this patient need to follow up with a cardiologist, with the GI, with the rheumatologist, with the primary care. We're gonna order some blood tests for this patient, has to follow up with the primary care. So make sure discharge planning is appropriate too. Some efficiency tips, you guys are gonna learn from your seniors, residents, that you're gonna have template. Make sure about learn fast about the EMR, mobile application, time management strategies. You're not gonna spend 24 hours dealing with 5 patients. At the end of the day, you have life outside of the hospital. So you need to learn how to be efficient in time. You need to do everything, and at the same time, you need to have some time for yourself, your family, your life outside of the hospital. Research and academic opportunities. I'm not going to go in detail with this because you are going to learn and hear about that during residency, but make sure that you know the difference between the clinical trial, like if there is any participation in clinical trial, quality, usually for most of the residents, all of the residents, they will be involved in some quality improvement projects, case report and series, and systematic review, especially if you are planning to do fellowship. And those also will educate you more, because you have to do literature review. You're going to read more about the topic, so you'll learn. You're gonna increase your medical knowledge by just doing those stuff. Academic activities, some of you guys will have medical students. You will teach them, but they will teach you. Try to read about one topic before you round with the medical student. You will educate the medical student about this topic, and at the same time, you will remind yourself about that, like hyperkalemia. Any electrolyte disturbance. Read about it briefly, then go educate the student. Ask them a question. If there is any topic that you feel that you're not very strong in, ask the medical student to prepare this topic for the next day. Read a little bit about it. The medical student will read a lot about it. They will come. They will present the topic to you. You will hear some new stuff, and of course, they will remind you of the stuff that you already know. Conference presentation, publication opportunity, and grant writing experience. You are going to hear about that during residency, but keep your ear around to hear if you hear anything about publications, opportunities, conference presentations, case reports writing. So the benefits for the fellowship application, as I mentioned, for early career advancement, network building, it's very important, and knowledge contribution. Financial consideration, most of the residents usually they get the certain amount of salary per year, and this money will increase. This salary will increase every year. Know your benefits very well for financial planning. Try to start your retirement plan as soon as possible. Try to put some like you're not gonna have a lot to have for emergency fund, but try as much as you can to save some money monthly. It does not have to be from the first month or the second month. Monthly, take a small amount portion of your salary and have emergency funding plan building. If you are planning to do fellowship, it's different than if you're planning to do like hospitalist or whatever your residency is going to be, like you're going to be attending after 3 or 4 years. If you're planning to do fellowship, you're going to plan your financial plan differently. You're going to be saving more money during residency because you're going to have long way during your training to start getting the real money. Professional expenses, of course, like those, but those too early for you guys. Licensing fees, board exam, conference attendings. When you save some money, you can use those monies. And all of the hospitals, they have some called CME money. You can use them for conferences attending. They help you with the hotel, flights, and a registration to the conferences. Wellness and burnout prevention. This is very important, especially during residency. Like duty hours, work-life experience. I mean, now in fellowship, we don't like it's you cannot work than in residency, you cannot work than 80 hours in 1 week. You have to have 1 day off. During fellowships and during real life, you're not gonna have all of that. But at least during residency, especially now, a lot of stuff you're gonna feel overwhelmed. So make sure that you know what does burnout mean and how you can prevent it. So prevent, like the supporting resources, usually you can ask the chief residents, your seniors, your mentors, program director. You have some peer support group, professional counselor. There is no shame asking about this, but make sure to know how to recognize it, because if you don't recognize it, it's going to take you to a different life, and it may sacrifice your whole training. So make sure how to recognize it, and based on that, you will work on it. Make sure that you sleep well. When you go to bed, like have those 6 hours of sleep every single day. Physical exercises and nutrition. Make sure to hydrate yourself very well. Most of us will forget, like you start round at 7:30, pre-round at 7, and you're done with rounding at 1 or 12 or 1 or sometimes 2 o'clock p.m. and you forget that you did not drink any water. So make sure to hydrate yourself. Make sure to eat well. Professional development, Dr. Shadi Reyes, he will talk in details about the mentorship and how do you find your mentor, how do you build a relationship with your mentor. But this is just a briefly networking. You will have a lot of, it depends if you know what specialty that you want to do. A lot of professional societies for that, and local medical associations too. Try, it's going to be a little bit overwhelming to try in the first 6 months, but during your residency, try to find if there is any alumni networking. Try to get in touch with them. I still, until now, I get messages from a first year resident in my residency program asking me questions about how to apply to cardiology, what should I do, and stuff like that. So they try to reach out to me, and I answer them. Building network is always very important. So, and that also, like mentorship, as I mentioned, Dr. Shadi Reyes will talk about that in details. Leadership opportunities, residents committees. Most of the hospitals, they have a lot of committees, like educational committees, wellness committees, different kind of committees. Try to be involved in one of these at least from the beginning of the year. They will tell you guys about the committees that they have. Pick one of them that you feel that you will do some different impact in it. It will help you also to do some stuff that you enjoy. So try to jump in and join this committee. As I mentioned, all of the residents are going to be involved in the QI committee. So you will have guys a QI team. You're gonna brainstorm ideas about your QI project, teaching responsibilities between the medical students when you discuss stuff with your colleagues, your other interns, and administrative role that will like have you will see that during residency. It's not going to be in the first 6 months. So talking about specialty specific consideration, when I started, few weeks before I started the residency, I was thinking that I want to do hemo. I did clinical rotation at Brown for hemo. I was like, oh no, I can't do this. And then when I started my residency, I was like, you know what? I like GI. So because I had a GI elective was coming up, I was like, all right, I'm gonna explore the GI more. I like procedures. I might end up in GI. So when I did the GI rotation, I was like, no, this is not the field that I want to spend the rest of my career in. And then I was like, you know what? I want a procedure. I want to do a lot of procedures. So what other options left for me? I was like between pulmocret and the cardiology. I was like, and I was in ICU, so I did the pulmocret. I enjoyed it, but I was like, I want more procedures, more. I want to spend time doing more procedure rather than rounding and talking to patients, talking to case manager and stuff like that. And when I did my cardiology rotation, I explored the cath lab, I explored the EP lab, and I found myself I enjoyed the EP lab in my second year of medical resident, even though I did not understand a thing in the EP lab. But I was like, all right, you know what? This is something cool. I want to explore more. So I start exploring the electrophysiology more and more. And by the time I was applying for cardiology, I almost knew that I want to apply for EP. So do not close doors, open all the doors and explore all the subspecialties and go based on that. Of course, research your specialty. As I mentioned, you're gonna like find like if you want to do cardiology, you can sign up for free to be a member of American College of Cardiology, American Heart Association. You can send an email and sign up free for them. You need to know about the board requirements, career pathway. What are you gonna do after? What does electrophysiology means? What does interventional means? And the job market trend. I'm not gonna say that I picked EP based on job market, but when I was exploring the electrophysiology, I was like, all of the people that were telling me that I've asked, they were like, the job market for EP is excellent nowadays. For the next few years, it's gonna be excellent. I was like, okay, this is something good too. I did not pick EP based on that. I was already thinking about EP, but I've heard good stuff about job market for EP. So I was like, okay, why not? My friend, he was thinking about structural cardiology. Structural did not have at the end of the day, he applied for structural, but he knew when he applied that he is not going to have a good job market when he graduate. And he find a job now, but he struggled. So job market is not gonna, it's not deal breaker for your uh, for your decision, but it's something that you need to explore.
Sorry for interruption, Majid.
Yeah.
The time is up.
Yep. I have
Are
two
you able
slides.
to? Okay.
Yeah. I will wrap up. Yep. All right, guys. So key strategies: own your own patient. No one should know your patients more than yours. You gotta know the patient inside and out. Be dependable, show up early, follow up on task, be professional, be productive, ask questions. There is no shame of asking even the silly questions. Build relationship. Start with professional relationship for sure with every single one around you. And after that, you will have more friendship with people. Stay organized, time, time and task management. Ask for feedbacks always, and ask for the negative feedbacks before the positive feedbacks, because the negative feedbacks, those stuff that you're going to work on, improve, and your skills going to be improved if you work on those negative feedbacks. And maintain balance. All of us who have personal life, you gotta have some time for you outside of the hospital, and think for long term. Don't think about don't think about your career from your first day during the orientation, but this is something that you need to keep in your mind. So you've already achieved so much by joining us in this lecture. Adaptation takes time, so be patient with yourself, build a strong relationship, focus on patient care, and continue learning. You are international graduate. You they appreciate you. They love you as long as you are professional. Moving forward, guys, look up for challenges, contribute to your unique skills and perspective, help future IMGs succeed. I was in your shoes 8 or 9 years ago, and now I'm giving you this lecture. So one of you in the future will give this lecture. Make sure to help others. All right. Thank you so much. And I'm not sure if we're gonna have questions now or we're gonna jump to the next topic.
Thank you so much, Majid. There is definitely a lot to talk about, and you have given us like a really good introduction to the U.S. residency in the U.S. There is no better person to talk about this topic than you, and inshallah, we will have you to talk about the fellowship and career, inshallah, soon. I would like to talk. Okay, so next we will have our second lecture, and this is going to talk about the intern year survival guide, and this will be given by Dr. Danny Hadidi. He is now a resident at St. Luke's Hospital, St. Louis, Missouri. And without further ado, um, if you want to go ahead and share your slides.
Hello, good morning, everyone. Can you see my slides?
Yes, we can see
Yes.
your slides.
Great.
I just want to remind everyone we will have a quick Q&A. I'm sorry, a quick break after this lecture for 5 minutes, and we will save all the questions and answers at the end of the session um, uh, for this morning. Yes, go ahead, Danny.
Right. So, good morning, everyone. Today I'm going to be giving you some tips about how to survive your internship. Some of the things that you don't usually hear. Me, as a PGY1, I think I can tell you a thing or two about the things that might await you and how to deal with them properly. So, first of all, let's just start talking about I need you to realize that residency is not a job. You're not done with your education. But at the same time, you're not a medical student either. So you need to understand this new situation. Uh, with that being said, you're required to develop a new set of skills. So, for example, back when you were a medical student, just because what you do is that you read the question, you answer. If you know the information, you pass. Now, in residency, just because you know the information, that doesn't mean that you're going to make the right decision. So, this requires multiple skills. First of all, are you able to maintain your clinical judgment when you have high patient load? That's one. Two, are you able to recognize the situation? Are you able to read thorough the case thoroughly and correctly? So again, just because you know the information, that doesn't mean that you're gonna be taking the right decision. So you need to have the skill that you are able to apply what you know. So this is also very important. The second thing is, are you able to maintain this, as I mentioned, with the high patient load? If you're having like 8 patients on your list, if you're an intern, or 10 patients, or 20 patients if you're senior, are you able to do this? So this is also a skill that you need to work on. The other thing is, are you able to maintain clinical judgment and read thorough the clinical narrative if you are under stress? Say that you're in a rapid response or patients are deteriorating. Are you able to do this? So all of those skills, I believe, would be kind of new to you because you graduated from a medical school. You need to anticipate that this is it's all new situations that you need to work with and to be up to the challenge. The second thing is, which is very important, is to be curious. You are here to learn. In العامي they say لا تمشي شغل. Anyone could make things. ممكن واحد يجيب PA or MP, she could تمشي شغل. She could write notes and take history and put some orders. Anyone can do this. But here, you are here to learn. Don't make things. لا تخلي الcases تمر just to know. It's not an 8 to 4 job. You are here to learn. Ask question. Read between the lines. Make sure that you're understanding the clinical decision correctly, that you know what's going on. Are you sure that by the time you're alone, you're on your own, you're graduating from residency, are you able to make the same decision إذا ما كان في حدا حواليك? So this is very important. You have to be curious. You have to see كمان, as we're going to talk in a minute, and know what is the outcome of your clinical judgment. Is the patient going to deteriorate? Is the patient going to get better? And be curious about the case itself. Do you think that patients who present in a specific clinical condition, are they going to be stable? Are they going to deteriorate? Start building your own experience. Have your own نظرة للمريض, and be able to tell after a while that, oh, I think I have seen this case before, and I think this patient might make it, or there's a chance that this patient might deteriorate. Just be curious and ما تمشي شغل. This is very very important. الشغلة اللي بعدها إنه dealing with seniors and attending. Well, you're part of a team, and there are a few things that you need to keep in mind. First of all, is there's a lot that you don't know, and that's completely fine. People who think that they know everything, it's very difficult to deal with those people. You should be لازم تكون قابل للتعليم. People who are not able to be taught, are very difficult to deal with. People who think that they know everything are very difficult to deal with. You don't know much, doesn't matter how much you know, there's a lot that you don't know, and you should accept this. Otherwise, رح تتعذب بالresidency. That's one. Two, when you're dealing with your seniors and attending, there's a chance that they might be wrong. Even an attending could be wrong. And that's okay. They have patience load, they have long working hours. So just make sure when this thing happens, that you approach this in a professional way, and you don't just be ما تكون واحد rude أو ما يكون مثلا antagonize those people أو مثلا even if they were bad, or if they have like previous مثلا مواقف صايرة من قبل, just don't be unprofessional. Make sure that everyone can make mistakes. Just clarify, ask politely, double check. By the end of the day, what matters is patient safety. So do whatever it takes just to make sure that the right clinical decisions are being made. Communicate, communicate, communicate. I can't emphasize this enough. Always make sure that all the people who are involved in this patient's care are in loop. If the patient is going to be discharged, are all consultants on board? كل العالم موافقة? How about the social worker? Can the patient go? Does he need placement? So you're always part of a team. If something came up, just make sure that you're informing other people. Even if you're gonna make something happen, you're gonna make the decision. And you think that this whole thing ended, that's fine. Just make sure that people know. إذا مثلا patient صار في عنده new symptoms, just make sure that you're informing your seniors, you're attending. the consultants if that's relevant to them وما إلى ذلك. كمان في أمر آخر, communicate with the nurses also is very important. Even when sometimes you put specific orders for specific medications that, oh, give this مثلا blood pressure medication only if blood pressure مثلا is above مثلا say 160. When you put the order, you put the بالcomment تبع الorder, you put this. Sometimes it's not enough. Just call the nurse. Tell her, hey, we did this. We have this specific customized comment that we have for this order or for this medication. Just please keep this in mind. Communication, especially in internship, is a lifesaver. Because if you communicate, like there's big part of the responsibility or liability that would be, يعني تكون عملت قسمك. You did your job, your part. Don't forget to study. You graduated, congratulations, and you matched, perfect. But that doesn't mean that you're done with school and with learning. This is a lifelong journey. And just keep in mind that every time you see something new, just read up on it. This is the best way to learn. Make sure that every now and then with your ACP, there is a mix-up access. Make sure that you keep studying. ما تنقطع عن الدراسة. Internship is like so many things to learn. Learning the system and learning how to deal and to adapt to this new lifestyle is difficult. But just keep in mind that you are basically here to learn. This is not just a job. It's not 8 to 4 job. Track your patients. I always have in my chart, the EMR, I always have 2 lists that are separated. Lists for patients that are unique, and I keep them مثلا. Those are my patients for PGY1 that I found to be unique, or they have مثلا unique findings or whatever. And I have another list for patients that I would like to follow up on them. I think it's very important to recognize a problem, but it's also very important to recognize things that are not a problem, that are problematics. I remember that there was, for example, a patient that she presented early in my residency, and she had a diffuse lymphadenopathy, and I was like, was almost sure that this patient has cancer. And this patient was followed, and the lymph nodes, they did not grow. Actually, they shrunk. They went away. And I was like, oh, so this was not مثلا seeing lymphadenopathy is not مثلا indicative of like, oh, it's 100% going to be a cancer. So this kind of thing. مثلا كلياتنا بنعرف كيف انه مثلا patient who have sometimes مثلا patient with pneumonia, the radiological doesn't really correlate with the clinical improvement in patients. So I remember I had a patient who clinically مثلا improved. كمان هذا كان أول شيء بالresidency. Clinically improved, but no, radiologically he did not improve at all. And I was like, why did the pulmonologist discharge this patient? Doesn't make sense. But I tracked this patient, and in outpatient visit, patient was doing completely fine. So هدول الشغلات align also with being curious. So track your patient, know what's going on. This encounter that you see in a few days that you spend with this patient sometimes is not enough. You need to see the big picture. So track those patients, follow up with them, and make sure that you see the outcome of your actions. Did you do the right thing or not? Notes. Writing notes is also very important, especially for interns. Well, we don't really have notes in our system, so ببلادنا فهذا الموضوع شوي جديد علينا. Notes is where you put your thought. Notes is when you're done with seeing your patient, doing the rounds and pre-round or chart ما إلى ذلك, or the whole you go through the whole clinical judgment. Notes is where you sit and think. It's the time where you basically improve. So make sure that you're putting your thought. Say, hey, this patient has AKI. We know the patient has dehydration. Patient map 2 days ago was like 55. This is probably why patient has AKI. Put your thoughts in the note. Make sure that you letting people know what you're doing. أنا بتذكر أول أسبوع كنت أشوف الكونسلز بيكتبوا like 4 notes. بيجوا مثلا النوت تبعهم بتكون مثلا 4 سطور عفوا. That's it, they go. Some consults are like this. I was like, oh, maybe this is how I should do it. And I was like, بعدين الاتندنج تبعي قال لي إنه you should never write notes like this. You should put your thought in the process. I know that you know what you're doing, but that's not enough. You should make things clear ما إلى ذلك. هاي رقم 1. رقم 2, Notes are very important because you're probably going to be a primary team on your floors, and people are going to depend on it to communicate, to know if there's any updates, what's going on. So make sure that you have your notes well written, cleared. You have your thoughts put in them. Make sure that you have everything covered. And of course, every day as it goes by, make sure that you update your notes day by day. Of course, you're starting with a whole new different system. So there are a few things that you need to be familiar with. Working with EMR, if you haven't done enough rotations, that might be new. And even if you have done enough rotation, you might be working with a different system. But working with understanding the system is very important because this is how you basically read through the patient. So investing enough time in the EMR is something that's very crucial. We're going to be talking a little bit about reading through patient's chart in a minute. As for prescriptions, also different. You need to make sure that you have the right dose, you have the how many times a day, to the right pharmacy. And so all of those things you have also to keep in mind. If, for example, you have a patient who developed, for example, say AFib and patient needs or pulmonary embolism during the hospitalization, and you want to discharge the patient on anticoagulation, you need to make sure that in your prescription it's not like the patient's going to wait for a day or two to get the prescription. He needs to be continued 24/7 on the anticoagulation. So just make sure that you have the pharmacist in loop and reach out again, communicate. Of course, there are differences in insurance, and there are different parts of the team that you're going to be dealing with. You have the PA and MP. You have to be probably most of you know the physician assistants or nurse practitioners. Those are people that have a higher form of education than registered nurse. They usually you see them with consultants. What they usually do is that they do the follow-up visits for some consultants. Also, you keep them in mind, keep them in loop whenever you're doing decision. When you want to just discharge patients, for example, just make sure that you are communicating with them as well. The rapid response and code blue varies from one hospital to another, but in a lot of cases, it's the residents who are at least contributing to the rapid response. In some hospitals, there's a rapid response team. It's either attending or a PA or with a whole team of nurses and respiratory therapists and pharmacists. So that's something that you need to introduce yourself to as well. شغلة تانية هي social worker. Social worker are very important in the system. If you have a patient that needs to be discharged, can this patient be discharged home? Can this patient be discharged to a skilled nursing facility or to for example, rehab, or if the patient needs some, tools or adjustments or walkers or stuff like that, just make sure that the social worker are in loop whenever you're planning regarding the discharge. And sometimes you might need to inform them up front because their work might need some time. If they want to discharge patient to a skilled nursing facility, this thing might need a day or two. And just keep them in mind. Do the huddle with them in the morning when you have the whole people on the floor, on the attending, will registered nurses, will pharmacists, social workers, because they discuss what's going on with this patient and when this patient could go home. It's important to attend those huddles. It varies from one hospital to another whether it's mandatory or not, but it's certainly in the benefit of patient, and I would attend it every time I can. Next, we have the pharmacist. Pharmacists are usually very useful. They could give you, they could recommend specific medications instead of others. They could recommend specific doses, specific frequencies. Always reach out to them whenever you have a question about your prescription, if you're doing the right thing, if you're standing at the right place, if you're not sure if the patient is or is not going to take the medication at the right time. So I would certainly keep the pharmacist also in loop. Respiratory therapists are also very useful. Those are people who adjust the BiPAP, the CPAP, they do the breathing treatment. You see them during rapid response. and they are usually also very approachable. And they also do the pulmonary rehab. Consultation is different in this country than it is in our country. In our country, you could see a cardiologist treating a UTI, possibly if the patient has a UTI in his clinic. But here it's very different. And the other thing is, you could be surprised, and also this varies from one hospital to another, but the threshold to consult a consultant could be sometime high, could be low. It depends on the hospital and the setting. Sometimes you could see that cardiologist is being consulted for straightforward AFib. Sometimes you would see that there is مثلا some hospitals مثلا بيقولوا every COPD needs to be seen by every COPD exacerbation needs to be seen by pulmonologist just to make sure that there is an outpatient follow-up وما إلى ذلك. So you could see it now like, oh, I could have done this. Why are you guys consulting يعني حدا لهذا الموضوع? So that is something that you need also to be familiar with. And always don't consult or not consult alone. Just make sure that you're also communicating with your team, your senior, and your attending. Time management. This is a very important skill, and you're going to need it your whole life. You're going to be working, you're going to be studying, and you're going to have time for yourself and your whole well-being. So working on time management is something that's very crucial. And of course, there's the personal growth. Are you going to be doing research, do fellowship? Do you want to do what do you want to do exactly? So time management is a skill that you need to actively be investing in. Reading through the charts, I always look at it as having the detective mindset. You have a problem, you have a patient with a problem. What caused it? So you need to look at the patient chart, the presentation, you go through the vital signs and all of this. This is something that you know, of course. But what you need, what I want to mention here is look at the previous presentations, look at the previous hospitalization. Look at previous outpatient visits. Seems like maybe this patient has like a cardiac problem. He's following up with a cardiologist. Maybe the patient has severe lower urinary tract obstruction and he's been having some serious prostate problem, which could have explained his AKI. Always read through the chart. In addition to that, come on, whenever you have something new, try to compare it to what it was before. So if you have an EKG, compare it to what it was before. There's like more ST deviation, elevation or depression. How does the T waves look like? So all of those are things that you need also to keep in mind. Trending lab is tremendously important as well. Seeing how مثلا there is a drop in hemoglobin or ما إلى ذلك could also help you to have the full picture. Recognizing burnout has been mentioned before, but it's very, very important. Some people start very excited and they just go all in and they don't maybe يلاحظوا على حالهم إلا إنه هن they're in the middle of they're working so hard and they at some point after 7 or 8 months they can't really take it, but they start having burnout problems. بيصيروا less productive و less motivated. ما بياكلوا مثل العادة, they don't sleep well. It's very burnout is real and it needs to be recognized. And the best way to treat burnout is to prevent burnout. So make sure that you're sleeping enough, make sure that you're eating healthy and you're eating enough. And also sport is very important also in keeping things going and avoiding burnout. Make sure that you have a healthy relationship and you're having enough healthy social relationships as well. General tips. As you go through residency, you need to build your connections. Connections were going to help you whatever you're going to be doing, whether you're going to do a fellowship or not. Build a strong and good connections with the people around you. Try always to stay professional, which I think is going to be discussed in details after this. And just general tip, don't assume that people know doing the right thing all the time. Just double check. Did the seniors did what he said? Did he put the order that we talked about? Did the attending put the image that we talked about? مثلا احيانا even consultant مثلا they might مثلا they say مثلا we're going to be doing 40 lasix, they put 20. Reach out to them, double check with them. People do mistakes all the time. Just double check. يعني make sure that you're making sure that things are in the right direction. Yeah, that would be everything. Thank you.
Thank you so much, Danny. This is a really great survival guide. I wish I had someone like you to teach me and to tell me about these tips and tricks. Definitely very helpful, and especially from someone from hands-on experience. You're in residency now, and you gave us a really good information about how to survive for your first year. Thank you so much. Next, we will have
Thank you.
yeah, thank you. So next we will have our lecture about professionalism and work ethics in the US. I'm happy to introduce Dr. Tareq Alyousef. He is a very close friend of mine for many, many years. He is one of the founders of the SAMS Education Committee. He is the one who taught me in the interview skills workshop in 2009 along with other exceptional physicians. He is a cardiologist, but he is the chief of cardiology at Stroger Hospital, Cook County in Chicago. We are very happy to have him, and we are taking this time from his family, and we're happy to have him. Thank you so much, Tariq, for being with us, and I will let you take it from there.
Oh, thank you, Mohammed, for the introduction, and good morning, everybody, and congratulations all. I was assigned one of those topics that I find very challenging because it is very difficult to sell this topic as probably one of the most important things that you would navigate in your life here in the US. So it is usually a very boring one. I bet money that a lot of us would think that this would be something that I'm going to have to go through, and it's going to be a boring talk, and it's going to be a very hard sell for me to attract your attention. But I'll do my best. And I consciously avoided actually creating slides that I would share and show, and I wanted it to be more around a communication, us talking about this. And by the end of hopefully the session, I hope I will be able to tell you why it is very important to shift a little bit of your attention from what you were doing in the last, I don't know how many years preparing for this, into something that is not a major part of the culture that we came in from. And it's a major, major issue in the new culture that you're going to have to adapt to. Professionalism is not about being watched. It's about being worthy of the trust that no one can see. So as I said, it's probably going to be boring. I thought that I'm not going to be able to teach you and give you bullet points and give you probably checklists that is even going to bore you more. What I decided to do is to make this around stories, make you kind of feel the moment, probably a few minutes of meditation, what I call cognitive autopsies on what you've done and how would you react in certain scenarios. I want you to be honest with yourself while I present to you the information that I have in mind, the things that I've had in mind to share with you, and reflect for yourself. What would you do in those cases? How would you feel? And so on and so forth. I'm going to do a few things as an experiment during this presentation that I do want you to throw in the chat box throughout. Things that you think I've done professionally, things that you think I've not done professionally. And professionalism is going to be sometimes subjective. It's a perception. Sometimes it's objective. So I do want you to throw in the chat box for Mohammed, if you want, anything that you feel like I've done and I kind of violated some professionalism guidelines. Here's what I'm going to start with a prediction. And this prediction, I thought about quite a bit, and it's about if any of the people on this call, on this meeting, are gonna get into trouble in the next 3 years, probably in the next few years of their professional training lives. Why would that trouble, or what would cause that trouble? And I would bet you money it won't be because you didn't know medical knowledge, you didn't know medicine. It won't be because you were lazy. It won't be because you missed that diagnosis that everybody else figured out. And it wouldn't be because you did not study enough. If it happens, and I hope it doesn't happen, it will be around something that violated professionalism during your work. I bet you money on this. I hope none of you gets into trouble, but if you do get into trouble, I do want you to reach out to me and tell me that I did not get in trouble for professionalism issues, because I bet you money that's going to be the thing that's going to be the Achilles tendon in your career. Maybe you've documented something that you didn't do. Maybe you spoke sharply in front of somebody who's the wrong person. Maybe you cut corners, and probably you cut corners that everybody is cutting. It's just that they caught it. And you're here because you're smart. You're here because you worked harder than most of probably your peers. But what will protect you now is not your knowledge anymore. It is your compass. And that compass is called professionalism. We were raised from a culture that believes that knowledge is everything, and that if you study hard, read enough, and score high enough, the world will open its doors to you. In medicine, unfortunately, knowledge is only the foundation. It's not the house. It's never the house, actually. And you can be the smartest person in the room and still lose the trust of your patients with a careless word. You could diagnose rare diseases, but if you cut corners or disrespect a nurse, no one wants to work with you. So knowledge makes you competent, professional makes you worthy. And one fills your head, the other one shapes your soul. So why does it matter to be professional? Because it builds trust in moments when patients are most vulnerable. It defines who you are, not just what you are. It protects your future self from regret and your present self from shortcuts. It elevates medicine from a job to a calling. It ensures that in the silence, when no one is watching, you still stand for something greater than yourself. And it is the universal language of integrity across all cultures, all systems, all subspecialties. Take my word on this. You guys are a brilliant, brave, resilient people, but that's not going to be enough. How you act is going to be the thing that decides actually your professional career in the next few years. So let me tell you actually a story that one of my friends, somebody who I really trust, wanted to share with me when I asked him about this. And I kind of appreciate his honesty and sharing his vulnerability. And I'm going to narrate actually what he conveyed to me about his first day in his residency program. He said, my first official day as an intern was calm. Actually, it was too calm. I was assigned to the general medicine team. The team was kind, diverse, and supportive. I kept thinking, this is not the horror story that I was told about residency. No one yelled, no one humiliated me. I thought maybe it won't be as hard as they say. It was around 3:30 p.m. and the team was behind on notes. A patient has just transferred from the surgical service after an uncomplicated cholecystectomy. And the plan was stable post-op, medically cleared, monitor overnight, home tomorrow. The senior said, you don't need to see him today. He was just signed off. Just write a quick note to keep things moving. Use yesterday's template and copy forward. I paused. I had never laid eyes on the patient. No exam. The sign-out said hemodynamically stable, but I didn't see blood pressure, heart rate, labs from this morning, probably because it's a transfer day. I sat at the computer, I opened the chart, and I started typing the note. But something stopped me. I looked at the field for exam, and then I went to the signature line, and I asked myself, is this how it starts? Starts with a lie that I saw a patient? So I stood up, and I walked into the room of the patient, and the patient looked pale. He was breathing fast. His blood pressure was 80s. He didn't voices last night, and his heart rate was 122. Check the chart again. A hemoglobin drop from 13 to 11 was missed overnight. No one had noticed, not the nurse and not the team who signed out. So I called the senior, and immediately we paged the surgery team, and he was back in the OR within the next hour with an active intra-abdominal bleed, and he survived. And my team called me a hero. That night, I didn't feel like a hero. I felt shaken because I had almost written a note that might have killed someone. Not by doing something wrong, but by doing nothing at all. And the next morning, I rewrote the quote in my journal. Professionalism is not doing extra. It's doing exactly what you promised, especially when it is easier not to do so. And there was a paradigm shift in my life. You're not being watched, you're being trusted. And that's what makes this profession sacred. I do want you actually to implant this in your minds, that it's all about the trust. Your attending says, just say we offered the procedure and the patient declined. You know it wasn't fully explained. You know the patient nodded, but didn't understand. You know you'll be the one signing the note. What would you do? If no one is watching, what would you do? In an English-speaking patient, scared and isolated, clutches your hand after rounds. The team moves on. You have a lot of more patients to see. You're the only one she seems to trust. You have a bunch of notes to write. You have labs to follow on. You have services to call. And sign out is in 30 minutes. What would you do? Again, no one is watching. You could walk out. I'm not saying it's wrong or right. I'm just saying, what would you do? Answer that question for yourself, because that's going to dictate who you are. You realize that you documented something under the wrong patient yesterday. No harm was done. No one noticed. If you correct it now, it might invite questions. What would you do? No one's watching. A doctor makes a sarcastic comment about a nurse in front of others. That doctor is your close friend. Even the nurse laughs at it, but she looks really hurt. Everyone moves on, and you're not even a part of the conversation. What would you do? You're asked to present a patient you didn't fully review. You skimmed through the chart, but didn't see him yet. The attendant asked you a question. You could guess, and you're very smart. You know how to guess, and you could deflect. Or you could admit the truth. You didn't see the patient. What would you do? So professionalism is the quiet agreement between your knowledge and your conscience. To place the truth above convenience, duty above comfort, and the care of others above the pride of self. It's not what you do when you are supervised, but who you choose to be when no one else is watching. Because in the end, professionalism is less about how you are seen and more about how you stand for in silence. And I want to move to the practical part of things to summarize things for you guys. There are three major dimensions of professionalism. There's the internal compass, there's the professional conduct, and then there's something called relational ethics. Internal compass is who you are when no one is watching. and it usually is around honor and integrity, self-regulation, and altruism. Professional conduct is how you act. And under that comes accountability, duty, and excellence. And then under relational ethics, which means how you treat others, comes respect, empathy, compassion, and justice. Now, let's go one by one and just give you the definitions and how you should hopefully react in those cases. For honor and integrity, it means to act honestly, ethically, and consistently with your values. You document accurately, even when tempted to cut corners. You don't copy and paste without changing the context. That's considered unprofessional. Reporting safety concerns is another example. If there's anything, you don't cover other people's mistakes just because you have to support people. You report any safety concerns. You put the wrong order, go and admit it in a professional way to your seniors so they can help you correct the mistake. Self-regulation means monitoring your emotions and behaviors and performance. And that means this is a very common mistake that I've seen careers being terminated. You have to remain calm during conflict. Cannot raise your voice, cannot shout in front of patients, cannot shout in corridors and hallways, even if you're right. It's very important to also keep in mind that you probably should reflect after stressful shifts to improve every time, even if you did not say anything wrong. Sit down and say, could I have handled this better, more professional? Altruism is putting the patient's needs above yours. This means things like volunteering extra time for an insured patient, skipping a break to stabilize a critical patient. It is your right to eat, but is it professional truly actually to walk away from a patient who's dying because it's your time for lunch? I don't think so. Accountability, which means you own your own actions, decisions, and outcomes. Admitting a mistake will only make people respect you. Following through on promised tasks will only make people respect you. Those are major things that you will be facing on a daily basis and you're expecting to deliver. Accountability is a big part actually of being professional. Duty, which is being reliably available and responsive to patients' needs. Taking calls seriously, even when you are exhausted. Somebody pages you overnight and you wake up. And do you have to answer? Probably not. But it is professional to at least guide whoever is desperate for help, to at least guide them. Who should they call? Answer that pager. There might be something serious cooking. And the whole hospital probably would appreciate that, the whole team. Coming in during emergencies, even without complaints. And even if those are not necessarily your patients. Somebody who's coding on a team that only has one intern who's running the code. It might not be a bad idea actually to go and help, because you're going to be in that situation one day and you would appreciate help. Excellence, and that's commitment to continual learning and high standards of care. Examples include reading beyond what is required and pursuing feedback to improve. Respect, which is recognizing the inherent dignity in every person, listening effectively without interruption, valuing different cultural or religious backgrounds, and being on time. This is a big one for us. We come from a culture where flexibility is a good value, that you don't have to accommodate, you have to accommodate others people, times, and so on and so forth. Here, it is a very big deal when you are late consistently. Every time you're 5 minutes late, 10 minutes late, and always excuses, and you think you get away with it. But it's gonna, on the long term, stab you in the back, unfortunately. Empathy and compassion. Understanding the connection with others' emotional experiences. Examples include sitting with a patient who just received bad news, or adjusting the tone for a scared child or a scared skilled elder. And last but not least is justice, which is providing fair and equitable care to all, regardless of their background. Examples include advocating for language interpretation, going into a patient who speaks a language that you don't speak, and you feel like, okay, he's 80 years old and it's going to take me, I don't know, he's hard of hearing and so on and so forth. So let me just cut corners and move to the next patient. He looks good. That is unprofessional. That's not fair. This patient needs your full attention at that moment. Get an interpreter, talk to them, spend time, because that's fair and that's professional. Ensuring equal care for marginalized populations. And this is becoming a major issue in the US. Make sure you don't judge people, even if you disagree with their values or the things that they do. They still need your 100% attention, and they deserve it. I thought I would finish with a few things that are different in culture between the Syrian culture and the US culture. And I'm going to summarize things that I already talked about, but I have to emphasize for you, because it's going to be something that hopefully is not going to ding you, hopefully, at some point in your career. Punctuality. In the Syrian culture, time is flexible, and people are, and it's around people's times. So it's people-centered. In the US, it's very strict, and it's clock-based timing. Accountability. We talked about it. Documentation. In the Syrian culture, it's verbal. In the American culture, you have to document everything. If you didn't document, it didn't happen. In the Syrian culture, you have to respect the hierarchy. In the US, it's much less of an issue. You can say whatever you think is right, and that's the right thing to do. Emotional engagement. It's very high in the Syrian culture. In the American culture, it's more of a professional detachment is expected. I'm actually gonna end up with this. I do think my time is up. I do want you to believe that you represent more than you think. I do want you to believe that you're not just a resident, you're a legacy. And that legacy has to be built around what you want it to be built around. I do want you to know and believe that everything you do makes a difference. Don't say, oh, who am I to say this or do this? Everything you do makes a difference. I'm gonna actually stop here, and I'm gonna send this back to Muhammad.
Thank you so much, Tareq. This was a wonderful and moving talk. It was definitely not boring. It was actually really moving on. Um, I think everything I heard from your talk was about emotional things, about things that maybe we don't pay attention to. We try to stick to the materialistic part, the medical part most of the time in our work. But then we need to talk about sympathy, empathy. We need to talk about collaboration. We need to talk about teamwork and also professionalism. Thank you so much. And I would like to move to the next uh, topic. I will have so next topic will be Dr. Ammar Hatahet, and he will talk about the characteristics of an excellent resident. Dr. Hatahet, he's an internist and diabetologist in solo private practice. During his tenure on the academic faculty at Wayne State University, he served as the director of the ambulatory practices and interim chief of general internal medicine. In addition, he directed a medical weight loss program and was involved with clinical research surrounding diabetes and weight loss. After that, he was recruited to be the director of the primary care initiative at the Medical College of Wisconsin. Since 2004, Dr. Hatahet has been in clinical practice where he still teaches resident students from Michigan State University. Armed with his MPH in health management and policy from the University of Michigan and additional involvement in practice initiatives such as improving performance in practice initiatives, Dr. Hatahet practice was designated a patient-centered medical home in July 2010. He continues to be involved with teaching, research, and has been serving as the Director of Clinical Research at McLaren, Auckland, since January 2011. Most recently, he was named the chairperson of the corporate-wide McLaren Healthcare Institutional Review Board, and he's a diplomat of the American Board of Internal Medicine and the American Board of Obesity Medicine. I would like to invite Dr. Hatahet to talk to us about the characteristics of an excellent resident, and you can take it from here.
So thank you for having me today. I know actually I recognize some of the names. I'm also the internal medicine program director at McLaren Auckland in Michigan. So some of you guys have interviewed with me. First of all, I want to say congratulations. I understand most of you are already about to start residency. I hope that is correct. If you did not match this year, don't worry, you'll match next year. And if you match next year, you're going to match eventually. Everybody who's been actually on that path eventually were able to get in. Second of all, I want to thank Dr. Alyousef for his presentation. Absolutely amazing presentation. Because I'm going to allude to some of the things that we look at as a program directors. Again, this has been now 7 years into being program director. We take 8 interns every year in Pontiac, Michigan. So I'm going to say actually a few things about what we look for and how this actually jives very well with what was already been discussed. Do you want me to share my slide? Let me see here.
Yes, you can. I think
Yeah.
you should be able to.
Here we go.
Thank you.
So I wanted to make it really more like a short presentation a little bit and have time for questions, because I know as you start to embark on your new journey as a resident, life changes and a lot of residents have a lot of questions. So I'll try to go through this. So first of all, what it means to start residency. It is a new job. And what I mean by a new job, something that you're not used to. Some of the professionalism that was talked about, we've never experienced it. Back in the days, I graduated from University of Damascus in 1988. So this is before probably half of you were born, maybe most of you. We used to work every summer. As you know, in Syria, you just work in the summer. You don't just sit around. Then I came here and I started actually working at a gas station in 89. Nothing like residency though. One of the things that you figure out when you become a resident, that one is a new environment with a new title. So all of a sudden you actually have this MD degree behind your name. People look at you as a doctor, but you're really not a doctor, you're in training. So the environment that you work in, for most of you, unless you have done residency here in the US or somewhere else, is totally different environment. It's hard to describe what it means to become a resident unless you become actually a resident. Sometimes you hear horror stories. Sometimes you hear wonderful stories. What I tell my residents, residency does not need to be miserable at all. It is hard. There's no question. The expectations of you as a resident when you come in, you're going to be there from 7 a.m. until 5, 6 p.m. every day. Then you're going to be on call. You're going to be post call. Nothing like it in your real life. I promise you, it's like nothing. So that new environment that you work in, it's not only about the medical context that Dr. Alyousef was talking about. Let's talk about your interaction with the nurses, interaction with the patients, interaction with your superior, interaction with the students. You're going to be having all these expectations outside the norm. So to allow you to get into that, I'm going to talk about some of the skill set that you have to be able to acquire to really be successful in that transition. That same environment is also shedding on you basically new responsibilities, once again, that you've never had to see before, you've never had to endure. One of the things that you notice actually when you start your residency, when you start kind of putting orders in, back in the days that we used to write them, right? You guys no longer write orders. You have to put them in the EMR and the HR. When you click signature, right? You basically could be a death sentence for somebody or it could be a cure for somebody. Thankfully, in the residency environment, there are a lot of checkpoints. So you put in the wrong medicine, pharmacist is going to call you, the senior resident is going to check on you, what have you. But after residency, you're going to be actually being given that liberty to kill somebody with your pen, with your signature. So these responsibilities amount to life and death. And this is really what I want to kind of hone down on, kind of complement what Dr. Alyousef said. When people are now watching, you could still make mistakes. You could cover your mistakes, but the price that people pay, forget about your professional career. Yes, you could certainly lose your professional career. You could be kicked out of residency, but also people's lives are at stake. Something that should ever be taken lightly. Now, that responsibility is not only about doing the right thing at the right time, it's about showing up on time. It's about communicating with other people as well. So I'm gonna try not to repeat what was already said by Alyousef, because I said it was amazing. The new team structure is also another thing that we're not accustomed to. We, in general, the Arabic culture, the Syrian culture specifically, right? We all are bosses. Everybody has their own ideas. I know more than anybody else, particularly Syrian doctors. If you guys encounter, I don't know if most of you are in Chicago or in the Detroit area or where you are, but if you're part of the Syrian community here at large and you talk to one of the Syrian doctors who've been here for 10, 15, 20 years, they think that they know the world. This is our Syrian trade in general, our Arabic trade in general. We know everything. And sometimes we forget that we actually do not know everything. Not only that, but we're also part of a team. Our success individually and collectively is dependent on everybody in the team. I'm going to give you kind of a practical example. You put in an order for a patient and you think this is going to cure him from whatever it is. You discovered pulmonary emboli and the patient's going to die with hypoxemia. You're great. You put in an order for heparin IV, do this, do that, and the nurse doesn't get it done. It doesn't work that well. You did not communicate. You did not put in staff. You did not find the nurse, right? Or the nurse may have done it, but the pharmacist did not really do their job. Or the lab, you ordered that heparin bolus, right? And they did not check your PTT. Patient bleeds to death. So you're part of that big team. You're not the boss of the team. I'm the attending. I'm the program director. I'm not the boss of the team. We all work collectively. And this is kind of really important for a mindset for people when they come in. And I'll tell you what I've seen over the years. I've been in graduate medical education now since 1994. After I finished my residency at St. Joe's, I was chief resident, and I was on the faculty at Wayne State. So it's a little bit over 30 years. And we quite often forget we're part of the team. We're an integral part. We probably are the second most important part of the team after the patient, right? But that structure of a team is critical to work with and understand the roles of each of these team players. In essence, if you're playing any game and you're the team leader, right, you understand the importance of everybody on that team. Not only you understand the importance of that team member, but also you have to be able to communicate about your role, his role, her role, everybody's role. So one of the things that I think the biggest kind of changes that you'll encounter when you start your residency, like I said, first of all, you're going to walk into the hospital, you're going to see these big buildings, huge buildings. People are busy, people are running this way, that way, etc. Everybody's coming on time, everybody's sharp. You have all these wonderful responsibilities of taking care of patients. We're going to talk about that responsibility because it doesn't stop with only seeing patients. And now you have to work with this wonderful big team. And sometimes you look at your line and I'm like, I don't feel comfortable, or I'm not sure if I should do this or that. So that's one thing they're going to talk about. Another big change is actually the life shift. Whatever life you've been used to prior to residency is over. Let me repeat, it's over. Whatever kind of lush time that you had, extra time, I used to, got used to going to have coffee, or I'm spending time with my kids so often, or I'm doing this. Life changes in so many ways. The biggest change is the language you use. The language you use. When we get together, we often use Arabic language, right? We're at a picnic, nobody's spoken. When you shift to the hospital, in that environment, your sole language, and I mean sole, my residents are not allowed to discuss cases in Arabic at all, none. You walk into these doors, you're switching. And I'll tell you why it's important to switch. So when you start now speaking a different language, everybody needs, I'm going to talk about communication, so everybody needs to understand what you speak about. But the way you think cannot be thinking in Arabic and then translating to English. It cannot work that way. It's going to take you time. You're going to make mistakes. So you're going to have to start thinking now in English. Your dreams become in English. Your way of thinking in English. The language you speak in English. When you do expressions, you don't do Arabic expression and try to translate. It doesn't work that way, right? Then that life shift, not only now you have to, your mindset is now moved into different language, different culture, different everything. Now you have family time, like I was talking about. You're at work from 7 to 6 every day, and then you're on call, night call, or post call. You're drained, you're tired, you're exhausted, you're sleep deprived all the time. You're not going to catch up on your sleep. By the way, just to let you know, we have the ACG mini rules for how many hours and this and that. At the time when I was a resident, we didn't have any of it. But even till today, even with the rules, even on your post-call day, you're trying to barely recover. This is taxing, physically taxing. Thank God you guys are all young, you can do it. But it's actually physically taxing. This is tiring. So that is part of this life shift where it was lush before, particularly if you're taking quite a bit of time off between your medical school and starting residency. You're going to notice quite a bit of shift as far as demand, physical demand, psychological demand, social demand on your life. Another layer, which was kind of, which we'll look at, you're always under the microscope. You're under the microscope for two reasons. One, because you're an intern. You come in, everybody wants to watch what you're doing. You're a resident, you're a student, you're a nurse, you're attending. You've been watched all the time. So you, honestly, I mean, people don't realize, I know everything about my residents from A to Z. Even when they don't think that I know it, I know it. If they screw up, wallahi, before they leave the floor, I hear about it from the nurse. They haven't even left the floor. It hasn't been like 5 minutes. I get a text, a message. Your resident did this or did that. Or, you know, things that was talked about, they did not say the right thing or they laughed at the nurse. I get to hear it within 5 minutes from its occurrence. So one is everybody is watching you because you're an intern. Two, they're watching you because you're different. Now, people could say whatever they want to say. You're different than the other people. And they are scrutinizing you, whether we like it or not, whether we admit it or not. That's what happens. You have a different name, you have a different culture. Some of it because they're just intrigued, some of it because they're curious. But they're not going to look at you like Michael James, who grew up here, who speaks the same language, who have the same culture. Most of the time, they really want to know who you are. So you've been watched not only for the medical stuff, but for your conduct outside the medical stuff, the way you walk, the way you dress, the way that you say hi to people. That is all going to be looked at, which is, this is an added stress on top of everything else that you have to do, right? So let's talk about the things that you will actually wait until, here's your added stress. In the midst of all these things, new environment, life shift, stress, sleep deprivation, under the mic, all of those things, you're yet expected to study and excel. What do I mean by that? You think that you pass your USMLE. Great, that's wonderful. What about the boards? If you thought USMLE was difficult, wait until you get to the boards. Now, we don't wait for your residency to check on your ability to take the boards. Every 6 months, or we do it every 6 months, but it's once a year for the IT. That is the in-service exam. So you get to be checked out actually for medical knowledge, usually in August every year, depending on your residency. Then second year, then third year. We do another test actually in March, so we could monitor patient or residents' progress over time with medical knowledge. So on top of everything else, now you have to study, prepare for your exams, prepare for your boards, and like that is not enough, now you also have to do research and quality improvement projects. And you have to be cognizant of the social construct and social determinants. So you could imagine all these things together is what life of a resident is gonna be, right? Like I said, it's total departure from what you've ever been used to. It does not have to be miserable, but it's not gonna be easy. And this is one of the things that I keep telling our residents. You could still enjoy your residency depending on the culture that you build in. All right. So let's talk specific about this new job and what it entails. So I already talked about professionalism. What does professionalism mean? He alluded, I think, beautifully described to you guys what professionalism is. So I'm not going to go over that in detail. I'm going to tell you what program directors see and what we hear. One of the biggest things is promptness, being on time. I can't tell, and so I tell the residents, you know, I'm going to run at 9 o'clock. 9:01, if they're not there, I run without residents. It's their loss. But you know what that means? That means now me as a program director, I already checked. Dr. So-and-so came in late one time, second time. You know what happens third time? In the past, we used to kind of let it slide. They get actually now a letter of deficiency. We no longer tolerate this tardiness if it's perpetual. Yes, circumstances happen. People, sometimes are late, but you get to know, and you guys know your friends. You know who was late all the time. Even right now, if you have picnic every Saturday, or if you have a soccer game every Monday, whatever it is, and somebody always comes in late, that cannot go into the work environment. That will not fly. But this is only one kind of example of that professionalism. Like I said, I'm not going to say what Dr. Alyousef already said. The life shift that we discussed, the time, requires adaptation. What does this mean? That means that you have, again, to rethink your priorities. You really have to figure out what I'm going to do today, tomorrow. You have to plan. You have to figure out certain things that were not figured out before in your lifetime. It's not, this has to be deliberate, right? So as you go through the rigor of your daily, like I said, going to be on-call, post-call, you're tired, you're exhausted, but you're going to have to somehow figure out a way that I could make this happen. This is not a choice where, oh, I'm going to see how it goes or work. No. You're already committed to your residency. You're already committed to a career. This is what you've been dreaming about for years, right? You left your country, you left your place, you came in here, you took the exams. This is a no return point right now with your residency. So you're going to be successful. One of the things that actually I'll be reminiscent if I have not said this before. You guys, as you come in to start your residency, there have been thousands upon thousands of people like you who've gone through this, myself included, right? Again, I finished my residency in 1993. Since then, have been thousand before me have also come gone. They were all successful. They all made it. What the difference is going to be is, are you making it and enjoying what you're doing, or are you suffering? I don't know any doctor right now who's actually kind of professionally not successful, right? But that's not what it's all about. Doctoring is a calling, like Dr. Alyousef said, something that you actually want to be. It's not a job. It's who you become. So part of that is you have to adapt to your new lifestyle. This is a new lifestyle that you're going to have to adapt to. That residency is going to last for 3 years. Year one, I'll tell you, it's your worst year of your professional career ever. No questions about that. No question. You're tired again. You're behind. Nobody respects you as an intern, what have you. But you will make it happen through the adaptation. When you're under the microscope all the time, you have to remember, like I said, you have to have some resilience. It cannot be where you say, oh, I'm done with this. I can't handle the pressure. You will handle the pressure like thousands of people before you. What I would tell you, lean on other people, lean on your faculty. We have a robust mentorship program in our residency that actually started years ago. Every intern and resident is paired with an attending based on their background, based on their needs, based on their family circumstance. Why is that? It's your older brother, older sister, right? When you guys get into the midst of this whole thing about falling behind, my God, I can't treat enough. Oh my God, now my kids, my spouse, listen, what do you do? How do you maintain that outlook? How do you keep the resilience? You lean on your seniors. You lean on your faculty members. You lean on your friends. You lean on people who've gone through this before. You're not the first one. This is what I really want to assure you guys. You're not the first one. You're going to enjoy your residency. But as you go through it, it's going to be tough. And that's when you lean on these other people. Now, the learning requirements that I was alluding to, this is your exams, your studying, and your research requirement. The program directors, here's what we actually look at. We look at professionalism, like I said, that it's all domains. We look at you guys, have this person adapted? Are they now able to handle the pressure? Do they have that resilience? And the least important to us as program directors is your academic achievement. Dr. Alyousef said something, I think that's when I jumped on the call. He said that when you guys get in trouble as a resident, it's usually not for academic achievement. And he's absolutely right. When people get in trouble, it's for professionalism, for not showing up, for saying the wrong thing at the wrong time, right? For being unable to adapt, for not being able to accommodate this microscope scenario. But program directors, we look at these 4 different areas, and this lines up directly with these changes that I was alluding to. Are you maintaining your professionalism? And it's not only about showing up, it's actually about the way you dress. It's about the way you smile. It's about the way that you communicate. It has multiple layers. Same thing with the adaptation. Same thing with the resilience. One of the things, we're going to talk about some skill set that you actually going to have to be able to succeed. Let's see when we're staying on time here. Mohammed, if I fall behind, let me know, please. I think I have one more slide left.
Yeah, no problem.
Okay.
Go ahead.
Okay. So the program directors now look at your academic achievements as well. Why are we in academic achievement? You know what? In my program, we only take, when we interview only those who scored above a certain level. That certain level is 50th percentile for USMLE. So we know you could do the work. We know that you could do the study. We know that you could take the exam, right? The question is, can you study, take the exams under all these circumstances that we just alluded to, keep professionalism, and that is really the trick. When you're in medical school or when you study for USMLE, you know what? People take time off and they study for their USMLE and they take a year or two or whatever it may take. In residency, you're working every single day. You're going to work every single day. You have a family to attend to as well. And you have research to do. At the same time, you're required to read, study, and plan on it, right? So that raises the bar much higher than ever before. The exam that you guys used to take, again, whether it's USMLE 1 or 2, or even back in your college and medical school, things are different now. Now you have a full-time job in spite of all these things, and you're expected to pass the boards, and you're expected to pass the exams. Those are not an option. So that's what the program directors actually look for. Those are kind of, in short, the domain that we look at from the program director for year 1, year 2, year 3. Now we do monitor, so each residency will have something called Clinical Competency Committee. The Clinical Competency Committee assesses each resident every 6 months. It is composed of faculty members, sometimes nursing representatives, sometimes pharmacy representatives. And we look at the residents kind of 360 degrees at every level, at every kind of interaction, medical, personal, all those are actually accounted for in the Clinical Competency Committee report that they send me as a program director. Then I sit down with the resident and say, you did this, you did that, this was good, this was bad, right? But it gives you a chance to improve. And this is part of this adaptation about, I've seen residents, unfortunately, you sit down with them once, twice, 3 times, you tell them, this is not the way it's to be done. This is not the way it's to be done. This is not the way. And they keep doing it. You know what that leads to? Could be dismissed from the program altogether. Things to keep in mind. So now let's talk about the skills that you have to have. Again, now you know what the program directors are going to be looking for. You know what everybody else is going to be looking for in the hospital. You know what you're going to be looking for yourself for your professional development and for your sanity, to maintain your life, to really just have a family. These are the main things that I would tell you that are absolutely critical to the success of you and your program and your team. I put them as inherent because some people readily have them. Some people have to acquire them. Okay? Not all of us have positive attitude. Some of us just wake up in the morning on the wrong side of the bed all the time. We're just not very cheery people. That doesn't fly. That cannot happen. You cannot conduct yourself in a hospital as part of a team if you do not come in with a positive attitude. When I interview my guys, and some of you, if you have not gone to residency, may interview with me next year, this summer, I always ask about their attitude. If you have a negative attitude, nobody wants to be around you. Nobody wants to work with you. Nobody wants you on your team. Again, think in any other kind of team sport that you want to play. If you're the negative person, nobody wants you on their team. So if you don't have that as an inherent kind of things that you have as a characteristics, if you are not born with a positive attitude, some of us are not. I mean, naturally, not everybody is happy all the time, right? Then you need to acquire it. You need to learn how to adapt it and get into it. That's one thing that you want to do. Perseverance is another one. Again, some of us, most Syrians, I will tell you, most Arabs, most migrants are already have persevered enough. This is usually not a major issue because we have endured a lot of things, right? By the time that you travel, you come into this country. I was telling somebody yesterday, I chair the Institute Review Board for Mental Health Systems. I oversee all the research activity, and I was telling my assistant yesterday, when you come in here, you're a youngster, 22, 23, you're coming to a different country, you're learning new language, and you're expected to act like a doctor. Something that's totally, it's tough. You persevered traveling so many miles and going into a different country, the different culture, little support quite often. So you've done that. So again, perseverance is not the problem in itself as much as pursuing the new environment, the new culture that I just alluded to. You don't work like you used to. You have to raise the bar. You have to do something different to be able to get to the next level. Number 3, patience.
We would like to allow them to ask questions. We will start our second session at 11 o'clock. Is it possible if you can finish?
So this is the last slide. Yeah, Ahmed, this is the last slide. So those are the skills that you really have to have, right? Patience, something that you have to have. You cannot cut people short. You have to take a deep breath. You have, again, time management is, I think, where most of our guys fall short. Really. Time management is where our guys, like Dr. Alyousef was saying, we come from a culture where loosey-goosey. I'll be there at 11, I show up at 11:15. That does not work. You have so many responsibilities. You better be good at time management. If you're not, you acquire it. English language skill, that is your communication. Believe it or not, whether you like it or not, whether we like it or not, patience, not only your kids will make comments about your accent. People pay attention, right? People notice. So out of all these things, the English language skills is what you really want to master if you can, as much as you can. And the final piece of this is teamship, being able to work within a team. Like I said, we come from individualistic. We think that we're actually group people. We are not. We are always, all of us are bosses. We're the boss of everything. Nobody wants to work with anybody unless it's my way. That has to be scrapped by this side. So those are inherently, if you have them, that's great. If you do not have them, you better acquire them. And whatever else that you may need to make you successful. So with that, I'm going to stop, Muhammad. That was, like I said, my last slide. And let's see what you guys have.
Thank you so much. And we really appreciate having you on your weekend and taking you away from your family. And it was a wonderful talk. I think this is exactly what any intern or resident would like to know before they start residency, so they don't make these mistakes, and also to be prepared and to have this positive attitude. I'm gonna just share my screen. Okay, so now we're going to open it for questions and answers for the participants. So if anyone would like to talk, you can raise your hand, and I will let you in. And then if anybody would like to write their questions in the chat, you can definitely go ahead and write them down. So we will be taking questions until 11 o'clock. Maybe one of the questions, I don't know if Dr. Tareq Alyousef is still with us. Maybe I can ask you a question. What do you think about residents in general? They have a tough time to reflect. So they go to work, and then they spend their day like dealing with like a lot of new things in their life, and also at work, and then they come back home, and then they keep it to themselves. And I feel like one thing you mentioned that they should reflect. What are your suggestions about reflecting and how this would be helpful?
Thank you, Mohammed. A lot of things can be said there. What I would suggest, reflection is a skill that we definitely lack in general. So you're not gonna be perfect from first trial. What you need to do is probably, again, believe that it is an important part of your professional growth. And do it as a routine. And with time, it becomes easier, just like meditation. Like the first time you do it, you feel like it's junk. Like I don't know how to do this, and I don't know what I'm doing here. But with time, you feel like, okay, I'm actually discovering things in myself that I was not aware of. I become a little less sensitive to, because one of the things that I think a lot of residents especially from our culture, struggle with is the fact that feedback feels like an insult on you. You feel like that you're imperfect, and these guys are trying to criticize you, and these guys are trying to tell you something. Anything that they tell you, you take personal, and for some reason it doesn't help you. So reflection actually goes kind of in different directions. One, you seek feedback from people because you want to get better. And you seek feedback from yourself. Why did I do this today? Why did I not do this today? Do what I call cognitive autopsy on everything you've done. You made a mistake. Great opportunity actually an opportunity to improve. Making a mistake is your major opportunity to improve, because the minute you feel like, okay, I'm doing this again and again, you're not going to be able to realize that you're doing it as a mistake until actually somebody catches it or you catch it. And then you can again, correct it. I call them opportunities. This is how you grow professionally. So I don't know if it answers the question. I hope it does.
So let me add to that as well. That is excellent answer, Tareq. I think that's really, really good. All programs now are required to do wellness as well. Part of the wellness, we have, again, same thing. We meet with residents regularly. We ask them actually part of our evaluation, semi-evaluation, semi-annual. They have to go and reflect on their progress, on their pros and cons. How they get feedback is a big deal as well. But now it's part of each program based on the ACGME kind of guidance that you have to have a wellness program. My advice to you guys, if you do have an opportunity in your program for your wellness, do not miss it. We had one of our wellness events was bowling the day before yesterday. Only 2 from my program showed up. It's for the hospital, right? The intent of that bowling is really not to bowl. It's not to throw the ball. It's to work with others, right? To share experiences, to talk, bring your kids out. Let's talk about these other things. So these opportunities that will be given to you during your residency for that reflection, it goes usually through the wellness. It's usually highly structured. Take full advantage of it. On top of it, do what Dr. Alyousef said, do your own as well. But you're going to have, most of the programs will have it readily for you.
Thank you. So we have a question to you, Dr. Hatahet. So if a senior resident says to the intern, please put in the note that we have done this and this, or a specific procedure or a specific thing, but it didn't happen, and the senior resident is trying to put something that didn't happen. That's just an example. Like, how would an intern should react, and what should they do? How can they address this problem?
Okay, so first and foremost, your internal compass that was talked about is still your compass. So you're gonna go by your conscience. You cannot not do things right just because of somebody says so. Program directors understand the hierarchy. So interns are usually under the thumb of the resident, and they could make your life miserable, right? That's a given. However, you're still professionals, right? So one of the things that I usually recommend to my residents, now the program knows this stuff, by the way. We know which resident tells which intern to do what. Believe it or not, the word flies. We exactly know, and I know among all my residents who's the lazy one, who's the one who's gonna add, like cut corners, who's not gonna do the work. So we know. But for the intern, him or herself, you need to go to your program director and let them know. First, you talk to your residents, remember, senior resident, all they mean is just 1 year ahead of you. That's all it means. You both are professionals, you both are doctors. So this hierarchy has a limit to it, which is they just have more experience. They are not your boss. I tell them, in the program, I'm the boss. Your senior is not. They can help you get to the next level. But if you're going to be doing something against your conscience, you should never, ever, ever, ever do. Not with your attendings, not with your program directors, not with your seniors. That's it. You're going to hate yourself forever. So that's not going to work. But the way that you address it is, One, talk to the senior, them say, you know what, I don't feel comfortable. That's another thing that we don't really usually say enough. I don't feel comfortable. We never say it because it's not in our vocabulary. It's okay to say, I don't feel comfortable. It's okay to say, I'm not sure. I don't understand. I don't know. So if you're not comfortable, you tell your senior, I'm not comfortable doing this. If he or she insists, you go to your program director. I don't feel comfortable. You do not want to, again, downgrade your resident, right? But you don't feel comfortable, you're not going to do it. So there's a hierarchy actually where you take things up. There's a set of rules, and you're going to get this during orientation about what happens in conflict. We run something called crucial conversation in our program for all our residents. It's part of it, this kind of disagreement, what happens. But for the intern, I would say first step, tell your senior like a colleague. Remember, they're your friends. They're just 1 year ahead of you. They're not your boss. They are your helper. So tell them, I don't feel comfortable doing this. And then if that doesn't solve the problem, then you take it to the program director and say, you know what, this happened. Like I said, we know which of our residents are doing the shortcuts all the time. And same thing for your attendings, by the way. If you have an issue where you are attending, like, what Tareq was saying, that even if you're attending, sometimes the attending will tell you, just get the consent. Well, you didn't even tell the patient about what the procedure is. That is not good. So there's a recourse, which is you go back to your program director and say, what if you have an issue with your program director? Some of you will have one. There is a director of graduate medical education. There's somebody above me, right? There's somebody above him. So you take it as far as you can take without really compromising your conscience.
Thank you so much. I saw some hands were raised, but then I don't see them anymore. We still have 4 more minutes, so if you have any questions. Okay, so there is Adham Qamaruddin. Please go ahead, unmute, and you can ask your question.
Thank you so much, Dr. Tareq and Dr. Ammar, for this great presentation. Really appreciate the time you contributed here. I was wondering, there's a lot of levels, I think, when it comes to the approach that we can have to residency. But is there a way that we can approach it as something that can be enjoyed? And if so, are there any active steps that we can do to ensure that we can look at those 3 years as something that we can have excitement towards and have, I don't want to use the word fun, but, just...
Fun. It is fun. It is fun, you guys. And again, I would encourage you to talk to any of my residents and ask them, what do they do? It starts with you first. Remember, it starts with you, right? We expect people to be nice to us. If you're not the first person to be nice, there's not going to be reciprocity. Nobody's going to be nice to you. So you come in with a big smile. When people need help among your residents, right? Somebody is tired, say, you know what, I'll get you covered. You can initiate that culture of nurturing, of teamship. It does not have to be miserable. It is tense, no question, because by design, you're dealing with life and death all the time. You're, like I said, you're going to be running CPR in this. So it's intense, no question. But the camaraderie that you start with your buddies in your residency, that teamship, that's why we do the mentorship program. That's why I meet with my residents individually, each class separate, because we talk about your experiences as a group. It could be enjoyable, and you'll make good friendships with these guys that you've never met before, right? And I tell you, for us, it's like getting married to, for 3 years, and I'll be married to this person you've never met. You guys are going to be doing the same thing with your colleagues. You're going to be living with these people for 3 years or 4 years. So you initiate it. It does not have to be miserable, but you can set the tone for everybody. You guys meet together and say, we as residents, as a cohort, we're going to make this fun. We're going to make it happen. It will happen. It does not have to be miserable.
Thank you so much, Dr. Hatahet.
Appreciate the answer.
So we have 1 more minute, and Ala Saaduddin, very quick question, and then maybe we can get a quick answer too.
Ala.
Sorry.
Graduation. Thank you so much for your lecture. Why I'm actually anxious or afraid of starting residency is because I had a +1 year gap where I wasn't practicing or wasn't studying or doing anything right now before the residency. So My question is, how can I أعوض عن هالشي يعني how can I avoid making a lot of mistakes or being behind in residency because of this?
Yeah.
Don't worry. You guys worry too much. Wallahi, you worry too much. I'm telling you. You all have the right skill set. You go with the flow. Start July 1st, like you've been doing this forever. You're all very smart. We worry too much sometimes. You do your part. You show up on time. You do your studying. You'll be fine. You're not the only one who was out of training for a year or 2 or 5 years or 10 years. What do you think, Tareq?
I agree 100%. Here's actually the good thing. The good news in this is you work in a team. American system is built around teams, around systems. The system is going to fill for your gaps. You're not going to be thrown in the jungle and go practice medicine. There are a million people. All of them are resources. People who are above you. Your students might help you. Like a lot of American, you will have probably American students who are going to be rotating with you. On my first day, I can tell you, they were the ones who are showing you how to put orders, how to write my notes, and so on and so forth. You have a pharmacist, you have a physical therapist, you have a dietitian. All of these guys, use them as tools, as resources for building up your knowledge. Put an effort, lift up your sleeves, and start reading. You're going to catch up very, very. Here's actually something another bet. I love betting. I make a fortune out of it. If you spare 1 to 2 hours a day, every day for reading, I bet you money you're going to be the top of your class by the end of your. And you can call me back and tell me you were wrong about this. It doesn't take much to catch up on medical knowledge gaps. I'm not minimizing it, but I'm just saying it's not going to be your major issue. The major issue is going to be around what we discussed, knowing exactly actually how to perform, keeping your cool, keeping professional, respecting your patients, adapting to the new culture, and so on and so forth. The fact that you are here today, natural selection already took place, and you're being naturally selected to be here. And I can tell you, you're above a certain bar now that you're here. So I wouldn't worry much.
Thank you so
just
much.
one comment. Just
Okay,
one
quick
minute.
one, Majid.
Yeah.
Go ahead.
First day of me in residency, I got signed out for 5 patients. One of them has cirrhosis. I was like, I had mind block. I was like, oh my God, how am I gonna do the physical exam for cirrhotic patient? I went to my senior. I had complete mind block. I went to my senior. I was like, hey, I'm gonna ask you a stupid question, but like I need some help here. He was like, what? I was like, I feel overwhelmed. I don't know how to do the physical exam for cirrhotic patient. It's silly. Like you're thinking that you have a gap, you have some like gap in the medical like experience, but don't worry about it. I asked him. He was like, all right, let's go, let's do it together. I went with him. We did the physical exam together, and gradually, you're gonna regain your medical knowledge. You're gonna regain your physical exam skills, and you're gonna build on a daily basis. As Dr. Tareq Alyousef said, if you have 1 hour a day to read, you're gonna excel. You're gonna be the superstar in residency. 1 hour.
Thank you so much,
All right.
Majid. I would like to give a final thought about the whole session number 1. Um, my quick advice is be nice and care. These are the main 2 things. Be nice to everyone and care about everyone. And if you follow that, you will do great. By that, I will end the first session, and our second session will be moderated by Dr. Hussam Kiwan. He is a graduate from Ondukuz Mayes University 2023, and he will be starting his residency at St. Louis University in the internal medicine program. Please, Hussam, take it away.
Hello, everyone. Very nice seeing you in here, and thank you so much for bearing with us. I hope you all fueled with coffee or at least determination, because we are gonna start our session too. And it's way more about, how to do the real stuff, right? Like how to survive the chaos of pre-rounding and how to conquer the EMR and not to lose your mind while during your documentation or while signing out. So let's get started actually with Obada Daaboul, who is going to break down the pre-rounding and rounding workflow. Obada is a PGY2 at Southern Illinois University, يعني جارنا هون. He graduated from Damascus University in 2023. Obada, please take the lead.
السلام عليكم جميعا، بتسمعوني؟
Yeah,
واصل
Sami.
الصوت. ممتاز. طيب، أولا I will share my screen really quick. Right. So first of all بدي أتشكر سامز على المبادرة الجميلة، لأنه سبحان الله، مثل ما تفضل البريزنترز السابقين، إنه الميديكال نوليدج ما له مشكلة لما الواحد يبلش ريزيدنسي. قد يكون في إشكال صغير فيما يتعلق بالتعرف على الورك فلو، التعرف على السيستم. طبعا كله بالوقت بيمشي حاله وبيخلص، ولكن ممكن يكون في tricky couple of weeks يعني. بما يتعلق في موضوع ال pre-rounding و rounds، هي سبحان الله بتختلف من مشفى لمشفى، من بروجرام لبروجرام، ولكن في خطوط عريضة كله بيشترك فيها. قد تختلف من specialty لأخرى كمان، وفي خطوط عريضة الكل بيشترك فيها. أنا الليكتشر تبعي tailored into internal medicine، ولكن إذا في surgical upcoming surgical interns فممكن ياخدوا بس الخطوط العريضة والنصائح العامة، وإن شاء الله يكون ليكتشر مفيدة. الأوبجيكتيفز تبع الليكتشر هي بداية إنه بس نحكي شو الكومبوننتس تبع البري راوندينج، شو الانفورميشن that we need to obtain from the patient and the information that we need to review from the chart before seeing the patients. ممكن كمان نحكي على efficient focused bedside patient encounter، كيف نسأل الأسئلة focused based on what we collected، كيف نعمل focused and pertinent physical examination، ومن ثم كيف نجمع كل شيء data حصلناها وننظم أفكارنا لنجهز حالنا للراوندز، ومن ثم بعدين في الراوندز كيف نعمل presentation للمريض، كيف يكون efficient، يكون واضح ال clinical reasoning لما نعمل presentation. بس قبل ما نبلش، وهي هيك one slide يعني كلام نظري شوي فتحملوني، ليش مهم كتير إنه نعرف الورك فلو؟ ليش مهم كتير إنه نكون شاطرين فيه؟ صراحة هو ثلاث كاتيجوريز أساسية. فيما يتعلق في البيشنت كير، وهو الأهم، لما نحن نكون عندنا الورك فلو واضح، لما أكون أنا بعرف الورك فلو شغلي efficient وعرفان what to expect and what's expected from me، بقدر وصل ل safe and high quality care. التيم مثل ما بتعرفوا في intern، في senior، في attending، وخط الدفاع الأول هو الانترن. لما الانترن يشتغل بشكل efficient comprehensive، ممكن ينتبه لبعض المشاكل اللي مثلا قبل ما أي حدا تاني ينتبه له. بالأخير السينيور والاتندينج حيوصلوا ويقروا حيشوفوا الشارت، حيفحصوا المريض، ولكن الانترن هو أول حدا حيشوف المريض، أول حدا حيعمل chart checking. early identification of problems can help with patient care. ومن ثم كمان إنه الانترن اللي هو well prepared، عرفان وقت يفوت عند مريض شو بده يسأل، عرفان شلون بده يعمل physical examination focused، بيكسب ثقة المريض. المريض ما بيحس إنه فايت عنده واحد يعني آسف على الكلمة بس شوي هيك مخبص، ما له عرفان شو بده يعمل، بيفقد ثقة بالتيم لما يلاقي إنه الأمور مو واضحة من الميديكال تيم أو من الانترن. كمان ما يتعلق في التيم كوميونيكيشن، لما يكون في عندي ورك فلو واضح، لما أكون عارفان شو مهامي، عارفان أنا كيف أشتغل بشكل efficient، هالشي بيخلي إنه كل التيم يكون على صفحة واحدة. هذا الشي بيخلي إنه الأخطاء تقل. وهالشي يعني كمان بالنهاية بيصب بالبيشنت كير وبالeducational process والتريننج تبع الريزيدنت. والنقطة الثالثة اللي هي كمان مهمة كتير هي التايم مانجمنت. لما واحد يبلش صح، يبلش efficient، كل يوم يعرف إنه شو بده يشتغل، الخطوات اللي عليه، ما يكون شوي هيك ضايع، بكل نهاره بيصير أسهل. أما لما بهلش ضايع، بينسى شغلات، بتصير وقت بده يوصل لآخر النهار عليه كتير مهام، عليه كتير أمور لازم ينتبه لها، فبيكون الورك فلو تبع النهار كله يعني صار قايد بالحيط. فبداية التايم، الشغل efficient بيخلي إنه يكون في عندي smooth work flow of the day. أكيد مليتوا من هالكلام النظري، فممكن نحن نبلش شوي بالشيء العملي. بس هلا هذا كويك تايم لاين، كيف انا من لحظه فيق للحظه خلص راوندز، او لا لحظه اطلع من المشفى لما اكون على الفلور، سواء inpatient internal medicine inpatient family medicine، كيف بيكون نهار. قد يكون في اختلاف شوي بالتوقيت ما بين بروجرام وبروجرام، ممكن يكون في بروجرامز لها ستراكشر مختلف شوي، ولكن هي خطوط عريضة أتوقع الكل بيشترك فيها. بداية لازم يكون بالمشفى، خصوصي في المرحلة الأولى بكير قبل الساين أوت. فإذا الساين أوت تبدأ 7، ممكن أنا أكون في المشفى بكير الساعة 6، حتى في أول أسبوع ريزيدنسي ممكن تجي أبكر بشوي، حتى إنه بيكون عندك بدك يكون عندك مجال تقرأ وتلحق حالك أكتر. ف تعمل شارت تشيكينج للمرضى. انت اوريدي بيكون وصلك ايميل او وصلك مثل ساين اوت فلنفرض هلا انت اول يوم على الراوندز، بيكون وصلك ساين اوت من الانترن اللي حيترك التيم اللي انت حتستلم محله، فبيكون اوريدي بتعرف المرضى اللي بدك تشوفهم. فبتعمل شارت تشيكينج. حنحكي بالشارت تشيكينج على شو بدنا ندور، لكن انت بتكون قبل الساين اوت اوريدي عملت شويه، عندك فكرة عن كل المرضى، عندك فكرة عن الأوفر نايت إيفنتس، عندك فكرة عن subjective documentation from nursing team، objective vitals، labs, imaging. فيعني you have good idea about everything happened overnight. ومن ثم بيكون في المورنينج ساين اوت، يلي هو بيكون النايت تيم عم يعطي الأحداث اللي صارت اوفر نايت. لما بيكون ومن ثم ممكن أوقات في بعض البروجرامز بيكون في شيء اسمه مورنينج ريبورت، يعني النايت تيم بيعمل برزنتيشن لكيس أو they will discuss a paper، أو قد ما يكون في شيء حسب الدايداكتيك ستراكشر تبع كل بروجرام. بعدين بيكون في فترة قبل الراوندز يلي نحن هاي بنسميها بري راوندز، لما أنت تروح تشوف المرضى لحالك. لما بتشوف المرضى بتعمل physical examination، بترجع بتجمع أفكارك، تكون جاهز للراوندز. بالراوندز بتمشوا على المرضى، ممكن يكون بعض الاتندينجز بيعملوا تيبل راوندز، بعض الاتندينج ممكن يعملوا walking راوندز، بتختلف حسب ستايل الاتندينج. من ثم في فترة صغيرة make sure you discharge the patients that needs to be discharged, place orders, and consult subspecialties if needed. بعدين في نون كونفرنس، لانش بريك، حسب الدايداكتيك ستراكشر تبع كل بروجرام. آخر شيء في المرحلة ما قبل الساين اوت للنايت تيم أو للسوينج تيم، you finish your notes, follow up on labs and tests, update family. وأوقات ممكن يكون في new admissions, you take care of them. ثم تعمل ساين اوت، وهي التايم لاين يكون خلص لليوم. طبعا مثل ما حكينا في اختلافات من بروجرام لبروجرام، ولكن هي التايم لاين الخطوط العريضة. هلا حنبلش أنا شو بالبري راوندينج. عم بعمل شارت تشيكينج، شو بدي دور. كل اي ام ار له يعني بيختلفوا الاي ام ارات كيف تصيل هالمعلومات، ولكن بالنهاية كلهم حيكونوا موجودين. فبدك طبعا شوف ال vital signs overnight. Did patient became febrile overnight? Did the patient became tachycardic? في شيء hypothermia؟ أي شيء مو طبيعي لازم أنت تنتبه له، تكتبه، يكون في عندك نوت باد عم تكتب النوتس تبعك. الانز اند اوتس، الفلويد بالانس، نشوف مثلا المريض قديش how much did they make of urine, how much did they have fluid intake. كمان هذا مهم جدا. labs, writing pertinent new changes in labs. كمان هذا مهم. إذا في new imaging results كمان لازم نشيك، ننتبه إنه في شيء صار overnight، في imaging done لازم نحن follow up on، في MRI was pending، في echo كان pending، كله لازم نعمل chart نشوف إذا chart check نشوف إذا خلص. نعمل نظرة على الميديكيشنز، شوف شو المريض أخذ، شوف في عندي أنا حاليا schedule medications PRN medications. أوقات لازم نشوف الشارت الميديكيشنز، لأنه مثلا قد تكون مريضة على دواء ولكن they will refuse to take it، أو لسبب من الأسباب ما أخذ الدواء، فلازم نتأكد كمان من الشارت الميديكيشنز مو بس schedule medications. ومثل ما حكينا الأوفر نايت إيفنت، بعض المشافي النيرسينج تيم بيعمل دوكيومنتيشن إذا صار في يعني significant overnight event. بعض المشافي ما كتير هيك بيعملوا، حسب كمان ترجع للنيرس. ففي حال أنت بدك تعرف إنه صار في overnight event ومعك وقت، مو غلط كمان قبل ما تشوف المريض تحكي مع النيرسينج تيم، تسألهم إذا في شيء anything I need to be aware of يعني. ومن ثم نشوف في الكونسلت نوت إذا صار في أي new recommendations from different teams. إذا أنا عامل consult لكارديولوجي they recommended something that I need to be aware of، لازم أقرأ الكونسلت نوت تبعهم. بعض المشافي الكونسلت services they place orders، بعض المشافي الكونسلت services they don't place orders. فيعني ترجع حسب البوليسي عندكم. فلازم أنا كل الأحوال كون aware بالrecommendations تبع السب سبيشالست. وعلى الجانب كمان أنا بكون بتشوف البلان اللي سويناها في اليوم السابق، وشوف إنه هل فعلا حصلت البلان، هل صار شيء لازم يستدعي إني يغير بالبلان. بس هيك نظرة سريعة على البروجرس نوت تبع اليوم السابق. أنت هيك بهالمرحلة يكون حصلت كل شيء معلومات من الشارت، فبس ممكن على النوت باد تكتب إنه شو الأسئلة اللي ببالك تسأل المريض. على سبيل المثال مثلا نحن مريض جاي بكونستيبيشن، بدك مثلا تكتب على ورقة إنه أنا بدي أسأل bowel movements. يعني وهذا مثال صغير، بس أي شيء مشابه ممكن تكتب هيك سؤال صغير إنه شو بدك تسأل المريض. ممكن أنت بدك تعرف تماما شغلة معينة من النيرسينج تيم تكتبها عشان ما تنساها، إنه when was the Foley exchanged مثلا على سبيل المثال. مهم إنه تحط مثل هيك structure صغيرة، كيف شو البلان تبعك لمرحلة اللي بدك تشوف فيها المريض. بعدين ممكن تخلي ببالك إذا مثلا السينيور تبعك مشغول بهديك الفترة، أو إذا ما له موجود الاتندنج لسه ما وصل، شو الأسئلة اللي بدك تسأل السينيور، بدك تناقش معه قبل ما تحكي مع الاتندنج. ممكن أوقات إنه مثلا تنتبه على مثلا diagnosis، شغلة صغيرة أنت مالك تعرف عنها كتير، فتكتبها على جنب كمان إنه بدك تقرأ up to date، بس إذا زاد معك قبل الراوندز أو بس لخلص النهار. وممكن تعمل مثل assessment and plan سريع based on what you found on chart. طبعا هاي سكيل بتنبنى مع الوقت، ممكن مو فورا تكون جاهزة، بس يعني خلي الموضوع في البال دائما يكون مهم. لما نحن نروح نشوف المريض، الهدف تبعنا نتأكد إنه المريض ستيبل، نشوف إذا في new problems، وممكن نشوف إذا المريض جاهز للديشارج، وهذا موضوع مهم كتير، وهي سكيل مع الوقت بتنبنى. يعني التبس يعني صراحة هي بديهيات، ولكن لازم دائما تذكير، يكون في empathy مع المريض، يكون professional kind، نحاول إنه ما نتجاهل ما نتجاهل شكاوى المريض. أوقات قد يكون التايم لاين تبعي ضيق، بدي أروح أشوف كل المرضى، بس لازم وازن ما بين إني جاوب كل أسئلة المريض، ما بين إني أشوف كل مرضاي. ممكن أوصل لمرحلة المريض عم يسألني كتير أسئلة وأنا مستعجل، ممكن أقول له إنه أنا بعتذر كثير. I will come back with the whole team and I will try to address your whole all your problems. بس دائما be kind in the professional manner. شو بدنا نعمل مع مريض؟ بدنا نسأله الأسئلة اللي حاطينها ببالنا، الفوكس questions يلي نحن لازم ننتبه لها. هل المريض is he making good urine؟ أوقات مثلا إنه ما له charted urine output، فأنا بدي أعرف المريض if is he making urine، عنده new symptoms، how is feeling، في bowel movements، أي شيء المريض بده يخبرك عليه ممكن تسأله. بعدين brief focused examination. في بداية الريزيدنسي يعني at least in our program كان expectations إنه يكون شوي physical examination يعني شامل comprehensive، ولكن مع الوقت صار expectation إنه لا، يعني بس صرت بآخر intern year PGY2 عملت focused physical examination based on what you suspect. ولكن يعني بشكل سريع أنت مجرد دخولك المريض بتبلش الإكزام. المريض عم تسأله أسئلة، هو عم يجاوبك، أنت عم تكون عم تشوف الفيتالز طرف التخت، أنت عم تكون تطلع في اللاينز الفولي، إذا في chest tube، إذا مريض on oxygen تشوف how many liters. هذا كله لسه أنت ما لمست المريض. تشوف حالته العامة، بتشوف لون جلده jaundiced، in distress not in distress. ومن ثم الفيزيكال اكزامينيشن يعني from head to toe سريع جدا. you check the neck JVD lung auscultation heart auscultation quick abdominal examination, you check the pulse, you check the extremities، تشوف إذا في swelling. يعني هذا مع الوقت الفيزيكال examination shouldn't take you more than 1 to 2 minutes. ولكن في البداية ممكن الموضوع يكون أبطأ. ممكن إذا أنت مريض في عنده حالة معينة أنت you're gonna target this situation. إذا المريض عندك concerns of مثلا CVA stroke، ممكن تعمل more comprehensive neuro exam. ف you're gonna tailor the exam based on the clinical context. فهي الفيزيكال اكزامينيشن، ومن ثم بتعطي مثل ما حكينا ممكن تعطي ابديتس للمريض انه we checked your labs, your potassium level has improved، انه ممكن we might have to give you additional diuretic. Whatever the plan is, you just give the patient some kind of update. And then just let them know that I'm going to come back with my attending, I'm going to come back with the whole team, and we're going to discuss the plan with you in details. هلا نحن جمعنا المعلومات من الشارت، شفنا المريض، صار عندي كل المعلومات اللازمة لحتى أعرف شو البلان. فالهدف هلا حاليا من هالمرحلة إنه رتب أفكاري، اكتب على ورقة صغيرة، أو إذا أنت بتحب فورا على النوت تبعك ترتب أفكارك كمان، هي بتكون more efficient. شو البلان أو شو اللي صار overnight، شو حصلت معلومات من المريض من الشارت، وشو الانتربريتيشن تبعك لهالمعلومات. لما أنا وقتها عم أقول how to organize your notes, I mean your notes prior to presenting, or your notes that you're going to use when you're presenting the patient. أتوقع في lecture مخصصة إنه كيف تكتب note، كيف تكتب progress note discharge note أو consult note، بس هون أنا عم بحكي عن notes تبع أنت يعني your own notes. الستراكشر في عنا حنحكي فيهم بالتفصيل، ولكن في عنا two formats، السوب والابسو. معظم الحالات حيكون you present patient I think it's gonna be soap. بس when it comes to documentation, when it comes to writing notes, some EMRs, some programs they do the abso format. شو هي السوب، شو هي الابسو؟ السوب فورمات هي subjective objective assessment and plan. السبجكتيفز هي المعلومات اللي المريض بيقدم لك اياها. شو new symptoms من يعني from the patient standpoint, if anything concerning from the patient standpoint, this is the subjective. Objective هي details that we collected from chart review, from a physical examination. Yeah, that's basically it. بعدين assessment and plan يلي هي بتكون most times you should do it in a problem-based format. واللي هي مثل هالشكل. على سبيل المثال فالassessment and plan لمريض من المرضى pneumonia, the plan continue this antibiotic, we're gonna have trained white blood cells, you check imaging, chest x-ray, whatever. Problem تاني AKI, we're gonna train creatinine, IV fluid, and then the problem أو مو problem تالتة ولكن هي شغلة لازم دايما نفكر فيها disposition تبع المريض, which means are we gonna discharge now? Is he going to be sent home? Is the patient going to be sent to a rehab facility, extended living facility? Depends on the clinical context. فهي الassessment and plan in a problem-based format. رتبنا أفكارنا وصرنا جاهزين لنعمل presentation بالراوندز. بداية one liner, المريض ليش جاء على المشفى, overnight events, objectives and the assessment and plan as we discussed earlier. بس يعني شوية tips عن how to present أو يعني بس قواعد عامة. Be concise, clear and organized. ما في داعي تذكر تاريخ medical history كاملا للمريض لما you're presenting on a patient that the attending already know, that the whole team already know. Just be concise, one line, and then go ahead with the overnight events, subjective objectives, and then your assessment and plan. Try always to come up with a plan. أول شيء حيكون صعب إنه أنا جمعت المعلومات, صعب interpret this information into a plan, بس always discuss with your senior. وحتى لو ما عندك plan واضحة, try to share your thought process with the team. For example, this patient is his leukocytes is trending up. I think there might be some kind of infection. Maybe the patient is on steroids. I'm not sure what's going on. بس لما مجرد انك تذكر هالشيء بتورجي انك انت عم تفكر, وانت مجرد انك عم تحاول تفكر بهالموضوع بيسرع انك تتعلم. أهم معلومة, I can't stress that enough, I'm sure they discussed this in the ethics section or ethics session, never ever lie. أوقات أنا ممكن أنسى أعمل abdominal examination, أوقات أنا ممكن أنسى أسأل المريض specific question, فإذا attending سألني عنه أبدا ما لازم كذب. يعني صح it goes without saying, بس the amount of times that this happens with some interns يعني مخيف. مجرد ما حدا يعمل هالشي وينكمش بفقد الثقة. وحنحكي بعدين في ملاحظات عامة بس أخلص الليكتشر, إنه أهم شيء بالنسبة للمانجمنت تبع البروجرام أو للأتندينجز هي موضوع professionalism. They don't care as much about the medical knowledge as much as they care about the professionalism. So never ever lie. وإذا ما بتعرف, just honesty is better than guessing. فأنا يمكن مالي منتبه للوقت, ححاول أكون سريع. فإكزامبل سريع, checklist. I asked ChatGPT to create a checklist from my slides. فبالبري-rounding وصلت على المشفى, مريض 73-year-old, history of heart failure, reduced ejection fraction, hypertension, diabetes. صار له 3 أيام بالمشفى, heart failure exacerbation. You check the chart, vitally he's tachycardic, he was not this way previously, febrile multiple readings. Now he's hypoxic, requiring 2 liters of oxygen supplementation. His baseline is 0 liters. You check ins and outs. His net fluid balance is almost 1 liter. You check labs. The leukocytes are trending up. Creatinine is trending down. Potassium is trending down. No new images. You ask the night nurse, tell you that the patient was anxious overnight. You check consults note, nephrology is on board. They think this AKI is cardiorenal. They're just recommending diuretics. You check the previous plan, Lasix, TTE is pending, which is the echocardiogram. And then fluid balance goal is minus 2 liters. Now you collected these data, you're going to go see the patient. You ask the patient, how are you doing? You do a review of system. The patient tell you, I don't know, doc, I don't feel well. I don't have any pain, but I don't feel well. I feel short of breath. I feel like I'm having fever and chills. I do not have any bowel movement since admission, and I'm making good urine. Then while you're speaking with the patient, you check the vitals. You'd see the patient is tachy and the 100, still febrile, and still using 2 liters of oxygen. You do focus physical examination, and that pertinent findings is the patient having crackles, still have bilateral lower extremity edema. Now you collected all the data from the chart, from the patient, from the nursing team, and now you want to organize your notes, organize your thoughts. So as we discussed, we do the overnight events, fever, chills, shortness of breath, was hypoxic, required oxygen supplementation, the subjectives, how is the patient feeling, as I mentioned earlier. Objective, I combined all the objective details I obtained into one line so I can present them to the attending. So I write these down and I'm ready to present now. So I'm coming with the assessment plan. After discussing with my senior, after checking up to date, I have some idea. So the patient is now having sepsis. The patient, maybe because they are hypoxic, they're requiring oxygen, crackles, maybe they developed hospital-acquired pneumonia or other infection. So we'll do lab workup, imaging workup. Maybe I will consider starting antibiotics. Just write these down. Maybe my plan is not going to be implemented, but at least I have some thought on what to do. I'm coming up with the second problem, this hypoxic respiratory failure, likely pneumonia or heart failure exacerbation. Similar plan. Maybe for heart failure exacerbation, I need to increase the diuretics because the fluid balance is not at goal yet. The patient is tachycardia. This is in the sepsis, likely in the setting of sepsis, managed sepsis. This is just like quick notes on my thoughts about each problem. And when you write your actual notes, it's going to be more detailed and it's going to be, you're going to have more thought process in this. But this is just for your presentation when you present your attending. Similar goes to AKI, hypokalemia, and the chronic problem he has. So this way, you organize your thoughts and you're now ready to present to your attending. Similar to what we mentioned, just have the presentation brief, structured, problem-based, and similar to the structure we mentioned previously. I think I'm on time. I'm just going to finish with the final advice. أول 6 شهور من residency are not meant to learn why we're doing a lot of things. If you're able to learn those, that would be great. But most importantly, you need to learn how to do things. And the rest of residency is tailored for you to learn why you're doing things. يعني, if you're able to master the workflow and the system in the first few months, that's perfect. And you're not going to be evaluated on your medical knowledge by the beginning of the year. Just try to be, just follow what you're expected to do and trust the process. It's going to be easy with time. مثل ما حكينا, your job is to know your patient, communicate clearly, and contribute to the plan if possible. And أهم شيء مثل ما حكيت قبل, being professional goes a long way. Preparation is confidence. First impression matters, and by first impression, I don't mean how is your medical knowledge. I mean how professional you are. Coming on time, being nice to your colleagues, being nice to your patients, and that will goes along. Ask feedback. بعرف بالpanel الماضي حكوا إنه reading 1 hour a day. Sometimes it might be difficult, especially in the first few months, but reading one topic a week إذا كان في consistency بتلاقي حالك هون لآخر الانترن year يكون عندك you read most of the bread and butters. You'd be able to be comfortably managing most of the most common cases. آخر final advice، وكمان أظن طرق لها الدكاترة في البانل الماضية، use your resources. في كل مشفى في pharmacist، في nursing team، في physical therapist، في dietitians، كلهم ممكن يساعدوك لتتعلم، ممكن يساعدوك في البيشنت كير. أنا وقت أكون أون كول بكون أحيانا في النايت شيفت لحالي، يوميا بدق للفارماسيست. أوقات ممكن بكون أنا بدي أعمل دوزنج لأناباريك، ممكن إنه بدي أعرف دواء معين شلون طريقة الادمنستريشن، بكون مريض مثلا عنده a lot of comorbidities، ما بدي أعمل interactions. فالpharmacists they're always helpful when it comes to your learning process. وشكرا لاستماعكم. إذا في questions أنا جاهز.
شكرا كثير عبادة. It was really very, very informative. I personally enjoyed it. We're going to keep the questions till the end of this session. And now we're going to start actually, let me share. Now we're going to talk actually about EMR. We have Bakr Alhayek. Bakr Alhayek is an intern at Advent Health in Tampa. He graduated from Hama University in 2022. Bakr, please take the lead.
مرحبا جميعا، السلام عليكم، العافية.
يا هلا بالحموية.
أنا على راسي. حأحكي عن ال EMR بشكل عام. ال EMR في له كتير systems بالولايات المتحدة يعني. ال EMR المستخدمه نحن هون بالمشفى عنا هو Epic، اللي هو فعليا أشهر واحد. فأنا هعمل شير سكرين للEpic Playground. هون يعني ما في أبدا لا معلومات مرضى ولا شيء. Everything here is just an example. ففعليا بالإبك في two systems that you're gonna use. في عندك system الانبيشنت لما يكون في rounds بالفلورز أو إلى آخره. لما بدك تروح على العيادة ممكن يكون في context ثاني أو system ثاني. هن اثنيناتهم بنفس الإبك بيتغيروا من جوا الإبك. فهي الواجهة العامة للانبيشنت. فأنت على اليسار راح يكون عندك الليست. خليني نشوف إذا فيني أعمل annotation. هون في عندك الماي ليست. هون الماي ليست هي الاشياء الليست اللي بيطلع فيها المرضى. ففي عندك الماي بيشنتس، في عندك الشيرد بيشنتس ليست. هون هي الاقسام اللي موجوده فيها الاقسام موجوده بالمشفى. يعني مثلا انا هون بادفنت هيلث اورلاندو في عندي اكسس، ادفنت هيلث سانفورد، اكسترا. فلنقل مثلا انا بدي اشوف الماي بيشنتس مثلا، فراح يطلع عندي هدول تو بيشنتس. هيك راح يكون عندكم الواجهه. طبعا هي الواجهه فيكم تتحكموا فيها مثل اي ثاني. مثلا edit criteria على سبيل المثال، بتتحكم مثلا شو الاشياء اللي بدك تطلع، مثلا patient admission info، مثلا احيانا بيحطوا مثلا bed number او الى اخره. فهي الاشياء انت بتتحكم فيها. هلا بشكل عام هي هيك نحن بنشتغل. فاسم المريض، العمر، الجندر، مثلا أنا بحط البيد نمبر، مثلا بيد مثلا 300 الى اخره. مثلا isolation info or infection info. مثلا في عندك الميديكيشن ريكونسيليشن، هل كانت الميديكيشن ريكونسيليشن completed or not. فراح نبلش نفوت على واحدة من التشارتس. فهي الواجهة العامة لإبك. أول ما بتدخل عليها، خليني بس شيل الانوتيشنز. اوكي خليهم مو مشكله. المهم هي الواجهه العامه. في عندك انت على اليسار اللي هي تشارلي، الاسم، الديت اوف بيرث، الام ار ان نمبرز. طبعا هذول كلاتهم عباره عن hypothetical examples، يعني ما في شيء حقيقي. هذا القسم اللي على اليسار اسمه الستوري بورد. هذا فيه تقريبا كل الاشياء اللي فعليا تستخدمها بالحياه اليوميه تبعك. مثلا في عندك اللابس، المايكرو، الايمجينج. مثلا اذا كان في عندك اي كي جي الى اخره، هون بيطلع الاكتيف ميديكيشنز، فيك تشوفهم من هون. هي كلها الاشياء السريعه. مثلا هي الاتندنج او البرايمري بروفايدر للمريض بالمشفى، وفي عندكم هون بتشوفوا كمان الكونسلتنتس اذا كانوا موجودين. مثلا هون في عندي انا سيرجن، في عندي هون بروسيجراليست، في عندي مثلا هون انه البرايمري هو الانترنال ميديسن او الكونسلتنج الى اخره. هون احيانا بيطلع عندنا السيل فونز تبع الاطباء السبيشاليستس يعني. فعاده احنا بنستخدم هدول، مثلا بحطوا their personal cell phones numbers، فنحن بنتصل فيهم ونبعث لهم رسائل الى اخره. هلا هاي هون تابس هدول موديفايبل، يعني فيكم تغيروا.
Please, how can I help you? Hi.
هدول التابس فيكم تغيروهم تعدلون على كيفكم. هدول موديفايبل، يعني فيكم مثلا تشيلوا تاب تحطوا تاب الى اخره. وطبعا كل هذا ثواني راح اوكي. طبعا كل هذا بيكون عن طريق هي اللي هون مثلا ديسبلاي مود، فول تكست الى اخره. وفيكم تعدلوا الاشياء، مثلا فيكم تحطوا مثلا الام اي ار اللي هي الميديكيشنز. في كثير قصص يعني، بس بالمفضله بالنهايه بالنسبه لي هن السمري، النوتس والاوردرز، واحيانا الشارت ريفيو. هدول الثلاثه اكثر شيء بستخدمهم انا بحياتي اليوميه يعني. هلا مثل ما حكى عباده، البري راوندينج بالاساس هون مرتبين يعني. فانا مثلا اول ما في الصبح بدي اشوف المرضى تبعي، مثلا بفتح على هذا المريض، بشوف الفيتالز تبعه، مثلا بيعطينا ترند مثلا مع الوقت والتاريخ والى اخره. مثلا المريض كان تاكي كارديك، هون هي البولس، المريض كان تاكي كارديك، بعدين هلا الهارت ريت تبعه نورماليزد، مثلا البلاد بريشر تبعه كان ماشي حاله، مثلا هي الاس بي او 2، مثلا المريض الساتوريشن تبعه منيحه. مثلا هون اذا كان على اكسجين سبلمنت، مثلا بهي هون على 2 لترز، تمام. هون الدليفري ميثود، مثلا هون بيحط لك النازل كانيولا، في منه مثلا بيحطوا لك الباي باب الى اخره. احيانا بيحطوا لك مثلا الكونتينوس او ميكانيكال فنتيليشن لما يكون المريض على منفس الى اخره. هون بيحط لك مثلا جراف اللي هو الترند بيعطيك اياه. هلا عاده انا ما بستخدم الجراف، عاده بستخدم الارقام. هلا مثلا الانتيك والاوتبوت. الانتيك والاوتبوت في كذا طريقه لحتى الواحد يستعرضهم. انا بحب التيبل، بس الناس في ناس بتحب هي، في ناس بتحب الشيء التراكمي، يعني انه مثلا هون انه هذا كل يوم عم بزيد عن اليوم الماضي، تمام. يعني هذا الشكل هون هو انكلودينج هذا مع اليوم تبع 31 الشهر. انا بحب هذا الشكل وبحب هذا الشكل. المهم هذا التاب تستخدموه اكثر شيء لما يكون مثلا مريض عنده congestive heart failure، مثلا بيكون في عنده renal failure، chronic او acute الى اخره. اي شيء له علاقه بالفوليوم فهدول بتستخدموهم مثلا. مثلا مثل ما شايفين هون النت input والانتيك والاوتبوت مثلا هو positive since admission، مثلا انه التوتال هو positive، تمام. مثلا المريض اللي عنده على سبيل المثال heart failure او in acute exacerbation of heart failure، والتارجت تبعيتكم انه يكون مثلا قريب للزيرو او حتى نيجاتيف ببعض الاحيان. نفس الشيء مثلا بالمرضى اللي عندهم ESRD على سبيل المثال end stage renal disease، او المرضى اللي عندهم اي شيء له علاقه بالفوليوم. الويتس هي مهمه. ليش مهمه بالمرضى الهارت فيلير اكثر شيء للامانه؟ شخصيا بستخدمها انا. بيوزنوا المريض تقريبا كل نهار مشان يشوفوا اذا هل في زياده بالوزن بتدل على فوليوم اوفرلود الى اخره. في عندي انا اللابس. هلا اللابس انا هي شخصيا كثير بحبها، كثير بستخدمها، لانه في تعطيك سمري. فيكم تختاروا الانترفال تبع انه مثلا قبل 24 ساعه، او مثلا بال8 ساعات، او مثلا كل 4 ساعات، او مثلا كل ساعه، او مثلا كل 15 دقيقه حسب يعني. انا عاده بستخدم 8 ساعات و4 ساعات اكثر شيء عشان ما يصير في يعني زحمه بالارقام. مثلا انا عندي هون السي بي سي، في عندي مثلا بلاد كلتشرز، في عندي الجلوكوز، في عندي الايميجينج، تقريبا في كل شيء هون بيتضمن كل شيء يعني. وفيكم يعني مثلا اذا كانت مثلا بدكم ريزلت تو فيو ات، يعني مثلا تكبسوا عليها بيطلع لكم الريزلت. مثلا هون البلاد كلتشر في عندي سودوموناز، بعدين هون مثلا بيطلع لك السسبتبيليتي، مثلا انه الانتيبيوتكس هون، السسبتبيليتي بانل هون، شو مثلا ريزيستنت، شو الاشياء اللي ممكن تستخدموها لهذا النوع من البكتيريا. بعدين في عندكم الراديولوجي هي كتير كمان مهمة. بيعطيك الريزلتس، بيعطيك الريد بيعطيك اللينكس لحتى تفتحوا الاوردر اللي انتم حطيتوه، سواء كان سي تي سكان او تشيست اكس راي الى اخره. بعدين في عندكم المايكرو نفس اللي موجود باللابس، بس هون انه بس تجوا عليها، يعني بيعطيكم اياها بنفس الشكل. مثلا هذا المريض مثلا عملوا له blood culture gram negative identified by PCR بعد ما طلع مثلا في عنده positivity بالبلود culture. فانه شو طلعت هي سودوموناز اورجينوسا على سبيل المثال. واذا بدكم تستعرضوا السسبتابيلتي بانل بتروحوا على بتكبسوا على هي الكبسه بيطلع لكم التيبل هاي. هلا الميدز هيستوري هاي انا عاده ما بستخدمه، عاده يعني النيرسينج هن اللي بستخدمه انا مثلا بدي اعرف مثلا هل هذا الميديكيشن عطى، هل هذا الميديكيشن discontinued، هل هذا الميديكيشن skipped على سبيل المثال. يعني هون مثلا انا عندي الزوفران لما مثلا بيطلع رقم هون اللي هو 0755 اللي هي الساعه 7:55 تمام. فبيعطيك انه مثلا انه given لونه اخضر معناته جيفن مثلا بالتاريخ الفلاني بالوقت الفلاني بالدوز الفلانيه وكيف انعطى مثلا اي ام اي في الى اخره. سبيل المثال هذا كمان هذا اي في مثلا هون بهذا الرقم هون الساعه 2:24 دقيقه الاريثرومايسين was DC'd D/C يعني discontinued، وهكذا بيعطيك مثلا continuous medications PRN medications. هلا الفيفرز عادة هي بتستخدموه لما بيكون في عندنا مثلا infection going on أو أنتم عم تتابعوا الفيفر بشكل عام مثلا، أو مثلا كم يوم مثلا هون حاطيكم الأنتي مايكروبيال وحاطيكم هون الأيام مثلا كم يوم صار له المريض على هذا الأنتي مايكروبيال وبيعطوكم البلد كولتشرز. في هون الأنتي كواجوليشن بالعاده هلا هم ما في شيء، بس يعني بالعاده بيطلع انه مثلا المريض هذا على اليكويس اللي هو الابيكسابان او على زاريلتو او اني تايب اوف انتي كواجوليشن. هلا في كمان واحد ثاني بس ما طالع هون الجلوكوز انا كثير بحبه مثلا المرضى اللي عندهم دي كي اي، المرضى اللي عندهم اي تايب اوف جلوكوز uncontrolled مثلا هايبرغلايسيميا او الى اخره. هلا بنيجي لهذا التاب اللي هو هذا كل يوم رح تستخدموه. هذا التاب هذا عبارة عن النوتس. هون في عندكم تابس كثيرة، في عندكم progress consults procedures HMP discharge إلى آخره. هلا هون تعملوا create new note. طبعا هون التمبلتس بتختلف بقى، مثلا أنا بدي أحط مثلا HMP على سبيل المثال بيطلع لي هون مثلا هي التمبلت ما أنا بستخدمها، بس يعني بشكل عام هي هيك. مثل ما حكى عبادة بال HMP بيكون عندكم chief complaint history of present illness، هدول تشوفون كنتوا بأسئلة الوورلد او بأسئلة استقبالات مريض عمره كذا كذا مع صوابع كذا كذا اجى عم يشكي من كذا كذا الى اخره، وبعدين بلشوا تستطردوا بالقصه شوي شوي. بعدين عندكم الميديكال هيستوري، سيرجيكال هيستوري، البريسكريبشنز prior to admission الى اخره، الفاميلي هيستوري، سوشيال هيستوري، هذول كلياتهم اوتو بوبيوليتد، بس في كثير اوقات مرضى بيكونوا جدد بدكم تعبوهم انتم. في الريفيوز اوف سيستم، في عندك الفيزيكال اكزام، بعدين في عندك الاسسمنت بلان. هون الاسسمنت بلان بتحطوا الاسسمنت تحت البلان. في عندكم تو تايبس، يعني في كثير ناس مثلا بتحط الاسسمنت يعني البروبلمز كلها مع بعضها، في ناس بتحط البلان كلها مع بعضها. انا شخصيا for educational purposes مشان ما الواحد ينسى شيء، انا بحط كل اسسمنت لحال. يعني بحط مثلا acute hypoxic respiratory failure على سبيل المثال مع مثلا الشيء المتعلق فيه على سبيل المثال acute exacerbation of congestive heart failure، هذول اثنيناتهم مثلا مرتبطين بعض فانا بحطهم مع بعض. بحط مثلا انه hypoxic respiratory failure is secondary to CHF exacerbation الى اخره، وبعدين بحط تحت البلان. هاي بالنسبه لل HMP. مثلا اذا بدنا نحكي على البروجرس نوت. progress note هي المتابعات اللي هو تماما مثل ما حكى عبادة SOAP note subjective objective واسمنت بلان. تمام. subjective مثل ما حكى عبادة يعني ما مشان ما يصير في redundancy شو حكى المريض. الاوبجكتيف هي الاشياء اللي الفيتالز الفيزيكال اكزام الى اخره واللابس. الاسمنت بلان هي المشاكل اللي كانت اجى المريض فيها او المشاكل النيو اللي طلعت. مثلا هون هي ال HPI هذا HMP مريض كذا كذا active problem list review of systems objective assessment plan. تمام. هلا في مثلا الكونسلتس بتشوف مثلا هي النوت مثلا من الجي اي فيزيشن بيحط لك مثلا الانبيشنت كونسلت مين عمل الكونسلت شو سبب الكونسلت الابدومينال بين مثلا بعدين بيحط لك تحت هو الاسمنتوم بلان تبع الكونسلت نفسه. في هون النوت رايتر هذا بيرسونلي ما بستخدمه كثير بستخدمه مثلا لما بعمل بروسيجر مثلا بالاي سي يو بيحط لك مثلا هيك مثل اشياء اوتوماتيكيه انت بتختارها ولحاله بيكتب لك النوت. عاده انا ما بستخدمه بالحياه اليوميه غير بالاشياء البروسيجرز يعني. بعدين الاوردرز كمان هي كثير مهمه. الاوردرز في كثير طرق تستعرضوها. الاكتيف اوردرز اللي هن هلا عم بيصيروا يعني في السايند اند هيلد. احيانا شو بصير لما يجي المريض على المشفى جديد بتحطوا الاوردرز تبع الادميشن اوردرز وبتعملوا له ساين، فهي الاوردرز بتروح على السايند اند هيلد. هلا اذا بدكم تعملوا له ريليس فبتحطوا هون ريليس اوردرز مثلا كليك هير تو ريليس سايند اند هيلد اوردرز بيطلع لك كل الاوردرز مثلا الموجوده هون تختارهم اللي بدك تعمل له ريليس وبتحط ريليس هون بيكون في عندك زر ريليس وبعدين بيرجعوا بيطلعوا بالاكتف. هلا هي الواجهه تبع الابيك جديده ما كانت هيك. مثلا هون search for new orders هي كانت هون. خليني نشوف اذا فيني اعملها. بعتقد فيني اعملها على جنب بس عموما مشان الوقت. في عندكم الميديكيشن scheduled PRN الدايت respiratory lab nursing الى اخره. هلا scheduled هي الاشياء اللي بتنعطى للمريض بشكل scheduled يعني انه مثلا كل نهار بدي اخذ مثلا سيفترياكسون مثلا كل نهار بدي اخذ ليسكس الى اخره. هون في عندكم الانستركشنز مثلا عم ياخذ مريض 20 ملغ اورال ديلي الفيرست دوز مثلا امبارح كانت على سبيل المثال 30/5. البي ار ان يعني از نيدد. هون في انستركشنز فانتم ما لكم علاقه بولا شيء من هدول الانستركشنز كلياتهم بيجوا للنيرسينج. انتم بتعطوهم الانستركشنز وهن بيطبقوا. الدايت اند نيوتريشن مثلا في عندك او في عندك الادولت ام بي او دايت. طبعا هذا بيتغير مثلا حسب انتم شو بدكم المريض يكون. مثلا ام بي او with ice chips مثلا او الام بي او with sips of meds ام بي او with sips of clear liquids الى اخره. في عندكم الادولت دايت اللي هو بتختاروا مثلا كاردياك دايت رينال دايت كله بيكون موجود بالسيستم. اللاب شو هن اللابس اللي بدكم اياها سي بي سي سي ام بي الى اخره. مثلا نحط على سبيل المثال سي بي سي. فالسي بي سي بيطلع لك لما تحط هي الواجهه بيطلع لك هيك مثلا سي بي سي او سي بي سي مع اوتو ديفرنشيال اف انديكيتد. يعني لما يكون في ابنورماليتي بالسي بي سي بيعمل لحاله ريفلكس بيروح بيعمل ديفرنشيال. مثلا لنقول نطلب هذا الشيء مثلا بيطلع لك هون سي بي سي with manual differential. مثلا اذا بنطلب مثلا سي ام بي بيطلع لك سي ام بي هون. لنقول نطلب مثلا renal function test يطلع لك مثلا شكله هون ما في بهذا التريننج. اوكي بس هون بيطلع انه renal function test. نقول مثلا نطلب hepatic panel مثلا hepatic function panel. كل شيء هون بيطلع حتى الايمجينج يعني مو بس اللابس. يعني مثلا نقول نطلب chest x-ray فيك مثلا chest x-ray 1 view 2 views الى اخره. نقول مثلا بدنا نطلب ايكو اليب بتحط مثلا TTE complete او TTE limited حسب انت شو بدك او الاتندنج او السينيور قال لك شو تعمل. مثلا MRI يعني تقريبا كل شيء orders بدك تعمله بتعمله هون. خلينا نشوف شو كمان. اوكي في عندك الهوم ميدز. الهوم ميدز هي مهمه. عاده احيانا المرضى بيكونوا جايين جداد ما بيطلعوا كلهم فانتم بدكم تحاكوا الفارماسي ديبارتمنت مشان يعملوا ميديكيشن ريكونسيليشن الى اخره. الاوردر هيستوري هي بيطلع لك مثلا انه هذا الدواء مثلا انطلب بهذا الوقت بهذا التاريخ من قبل البروفايدر الفلاني. مثلا هذا الاوردر نفس الشيء بيطلع لك هون تفاصيل مثلا. هلا بعتقد تقريبا هي اوفر فيو سريعه عن هدول. هلا الشارت ريفيو كثير ناس عملت ريسيرش وبتعرف هي التاب لانه هي التاب الوحيده اللي عندهم اكسس لها. بيعملوا تشارت ريفيو مثلا بيروحوا على النوتس. هي النوت مثلا سواء من هذا الادميشن او من ادميشن قبله. تمام. هلا الادميشن والديسشارج. هلا مثلا قال لك الاتندنج انه احنا عندنا ادميشن جديد جاي من الاسعاف، فبتختلف السيستم يعني شلون بصير الادميشن بين المشافي، لكن نحن السيستم عندنا بيكون كالاتي: ببعث لك الاي ار رساله انه هذا المريض بده في ادميشن اوردر له، فانت بتتصل بدكتور الاي ار، بتشوف شو القصه، بعدين بتفوت لهون على هذا التاب ادميشن. ففي عندك هون على اليسار الادميشن اوردرز. الادميشن اوردرز هيك بتكون في عندكم الهوم ميديكيشنز، في عندكم الهوسبيتال اوردرز. الهوم ميديكيشنز هون المفروض انه يكونوا موجودين اذا كانوا ريكونسايلد او اذا كانوا مثلا محطوطين من قبل الفارماسي ديبارتمنت، لما بيكون عاده في ناس بتروح تسال المريض شو الادويه اللي عم تاخذها الى اخره، فهون بيكونوا جاهزين بالنسبه لكم، فانتم عندكم خيار انكم تعملوا اوردر او لا. الهوسبيتال اوردرز هن عاده يعني الاشياء اللي انتم تطلبون هون. هون بتحط مثلا admit to inpatient، مثلا admit to inpatient بيحط لك مثلا شو مثلا بيحط لك انه شو السيرفيس، مثلا هل هو بي ام تي بون مارو ترانسبلانت جاينيكولوجي انترنال ميديسن الى اخره، بيحط لك شو الليفل اوف كير acute intermediate care او intensive care، بيحط لك مين هو الادميتنج بروفايدر، عاده بيكون يور اتندنج الى اخره. هي كثير مهمه طبعا هون، وبتختلف باختلاف البروجرامز. بعدين في عندكم الديسشارج، كمان الديسشارج كثير مهم، وبنفس الترتيبه مريض انتم خلصتوا له العلاج تبعه بدكم تخرجوا، فنفس الشيء هون على اليسار في عندكم discharge orders. بالادميشن في شيء اسمه admission orders، بالdischarge في اسمه discharge orders. الdischarge orders نفس الشيء. الهوم ميديكيشنز اللي بدكم اياهم بدكم المريض يتابعها او يوقفها او بدكم تعدلوا عليها، تمام؟ مثلا نقول بدنا نعدل على الهيدروكلوروثايزايد او بدنا نقول للمريض يتابع فيه، مثلا بيطلع لك هون continue taking your other medications اللي هو هذا، او مثلا بدنا نعدل الدوز، تكبسوهم في قلم صغير، مثلا بدي احط مثلا دوز 12.5 ملغ، مثلا بيحط لك duration، بيحط لك قديش مثلا full 30 days تعطوه وصفه ل 30 يوم الى اخره. هون اذا في اي instructions بتحطوها للمريض هون، وهكذا. فيها الانبيشنت ميديكيشن يعني الهوسبيتال ميديكيشنز، يعني مثلا مريض لنقول اعطيناه زوفران كان عم يحتاجه كل 4 مرات بالنهار، ففيكم توصفوا له اياه بس مو الانجكشن طبعا، يعني الاورال فورم والى اخره. وهون في عندكم الهوسبيتال كورس. انا بحب استخدم الهوسبيتال كورس لانه فيك تلخص الاشياء مثلا مشان تحكيها للاتندنج او الى اخره. طبعا هون في عندك الهاند اوف اللي هو الساين اوت مثل ما حكى عباده، في كثير له ستراكشرز مختلفه. في عندكم severity summary to do list، مثلا severity هل المريض stable ولا هل المريض critical ولا هل المريض watcher الى اخره. summary يعني مثلا انه مثل ما قال عباده one liner، انه مثلا هذا المريض 60 سنه عمره 60 years old male who was admitted for acute hypoxic respiratory failure secondary to acute exacerbation of congestive systolic heart failure الى اخره. مثلا وهي الاشياء اللي عملنا لها. to do هي الاشياء اللي بدكم انتم الشفت الثاني بدكم اياه تابع عليها. مثلا مريض عنده جي اي بليد، بدكم تعملوا له مثلا هيموجلوبين مونيتورينج، بتحطوا مثلا follow up on hemoglobin and hematocrit every 4 hours مثلا الى اخره. ف هي وظيفه التاب. هي السايد بار سمري. هي السايد بار سمري هي صديقتك بشكل عام، انا بحب احطها هون لانه اسهل. في عندكم هون بالاي سي يو، اذا كنتوا باي سي يو كثير مهم تعرفوا شو هي الاكتيف لاينز. مثلا هل المريض عنده سنترال لاين، هل المريض عنده بريفرال لاين، هل المريض عنده بيك لاين، هل المريض عنده فولي كاثر، هل المريض عنده داياليسيس كاثر الى اخره. فبتحطوا عليها مثلا بتحط لك الشكل مثلا انه هذا المريض عنده peripheral IV was inserted on this date in this location، والعمر هي الاي في هي 1 day. هي كثير مهمه بالانفكشن كنترول مثلا، مشان ما يصير في عندكم مثلا catheter associated blood infections bloodstream infections او الى اخره. الميد dispense history. med dispense history هون بيعطيك الادويه اللي المريض صرفها من الصيدليه. يعني مثلا المريض اخذ لنقول كلونازepam لمده 5 ايام فقط، اخذه من الصيدليه CVS او والجرينز او whatever، بيطلع لك هون انه المريض صرف هي الوصفه بالتاريخ الفلاني من الصيدليه الفلانيه بهي الكميه. فهي كتير مهمة. سبسس تشيك ليست هي بتختلف بقى من مشفى ثاني، بس يعني في ناس مثلا تستخدم النيو ديفينيشن اوف سبسس، في ناس تستخدم الاولد ديفينيشن اوف سبسس، يعني حسب المشفى وحسب البروجرام. بشكل عام one last thing I want to mention quick thing، هذا الامباسكت. الامباسكت هي الاشياء اللي انتم لازم تتابعوا فيها سواء inpatient او outpatient. مثلا results ممكن يطلعوا لكم هون، مثلا انه هذا المريض عملنا له كذا، مثلا الفيتامين بي هي السي بي سي تبعه، هذا المريض مثلا السي بي سي تبعه مثلا طلعت هيك، هذا المريض مثلا البي ام بي تبعه طلعت هيك الى اخره، فبيطلع لكم هون. اذا كان مثلا في عندكم مريض بالاوت بيشنت اتصل فيكم مثلا بيقول لك انه المريض اتصل فيك الى اخره، عنده هي الكومبلين بليز ادفايس، هذول كل يعني الامباسكت هي ما لازم تكون مفلله عندكم، هي لازم دائما تردوا على الممرضات من خلالها مثلا بتشوفوا اذا المريض اتصل، اذا المريض في عنده اي كومبلين، بتشوفوا الريزلتس inpatient او اوت بيشنت الى اخره. ف اعتقد هاي كل اغلب القصص يعني اللي موجوده بابيك. في عندكم البيشنت ستيشن اللي هو مثلا بدي مريض مثلا لنقول روز مثل ما كاتبين هون، فبيطلع لك مثلا المريض اي مريض اسمه روز، بتكبس عليه بيفتح لك الشارت تبعه وهكذا. بعتقد انا خلصت يعني هيك comprehensive review تقريبا، ما أنا detailed، بس يعني انه I could I did it as best as I could. إذا في أي أسئلة أو concerns I would like to answer them and address it. Sorry for taking so long.
Yeah, no worries. شكرا كثير بكر. كثير كانت صراحة informative. I know الإبك is a maze يعني you can spend like the whole day talking about it. Thank you so much. Now we're going to start with Anas Hashem. Anas, he is internal medicine chief resident actually at Rochester General Hospital, and he's also an incoming cardiology fellow at Houston Methodist. Anas, please go ahead.
Thank you so much, Hassan. الله يعطيكم العافية شباب. ما شاء الله بكر يعني he wrapped up everything related to Epic ب short period. احنا هذا العادة عندنا اياه course over 4 hours، ما شاء الله هو خلصه كله ب 20 minutes which is great. اطمنوا يعني ان شاء الله. I know it might sound a lot انه في Epic و new system و inpatient outpatient، بس ان شاء الله you're gonna have like a detailed course on how to use the system بالمشفى تبعكم. وبعدين it varies from a hospital to another hospital. There are different systems that we use. First of all, I want to thank SAMS ما شاء الله يعطيهم العافية for setting this up. نحن يعني we would like to give back to our community. Hey, this is our opportunity to give back to all the Syrian students. Second thing that I want to talk about is congratulations to everyone who ended up matching. كل التوفيق إن شاء الله. It's a great achievement. Be proud of yourself. For me, I'm going to just go quickly over the data gathering part that Obada and Bakr talked about. Inshallah, I'll go more in depth regarding documentation and the handoff, how to do it properly. Before going there, I want to talk quickly about the RIME learning module that we use at our hospital. And the residency program تبعنا, we expect the residents to grow gradually. فأنت initially the RIME module stands for different kind of acronyms. The R stands for reporter. As an intern, we're expecting you, especially in the first 6 months, just to be a good reporter. So come early in the morning, gather the information, collect the data in an appropriate way, try to arrange it, try to express it while you're precepting and discussing, running the list with the attending. هي part of the reporter that we're expecting you to be. هو بس انت as long as you're professional, you're coming, showing up on time, inshallah, you'll be a great reporter. Around the end of your first year, we're also expecting you to interpret the results. حتى earlier, even during your reporter phase, you can try to incorporate more interpretation of the findings. So we have this lab findings, this is the imaging, these are the patient's clinical manifestations and signs and symptoms. So my interpretation is the following. And then with time, you're going to start to build on the management, which is the medical knowledge that most of you guys are afraid of not having, but inshallah it's going to take, inshallah in the first few months you will be able to build it, and you're going to learn with practice and of course solving questions. E stands for educator. Inshallah, around the end of second year or third year, you will be able to teach the students, the juniors. Hatta as an intern, you can teach the students if you have like extra knowledge. Around the end of the first year, definitely you will be able to teach the students. As a second year, also you'll be able to be a good educator. Now, the objective of this talk, as we said, we're going to talk about the data gathering quickly. Obada already went in depth. Documentation. I'm not going to talk about the EPIC and EMR system. I'm going to focus mainly on documentation, different and most commonly written notes per se. And finally, the handoff. And with the data gathering, I usually divide it into different aspects. You have to collect the data initially from the chart review. So you would do a detailed, thorough chart review. And then also there is some of the data that you collected directly from the patient. And then you put on both data together and then you present it to the attending. And just a quick disclaimer, as what Bakr did, all the EPIC screenshots that I have here, they're from the hyperspace, like EPIC hyperspace training environment. So they don't represent any real patients. Now, for the data gathering, generally I have like a systematic approach before seeing a patient. There's the pre-rounding, rounding, and post-rounding phase. For the pre-rounding phase, just make sure that you do a detailed and thorough chart review. So why is this patient here? Why are they being admitted? And then go back to the prior hospitalization and recent admissions. Even if there are like any, the patient went to the clinic, for example, just go quickly review the chart. What was the recent, let's say, medication that was started to the patient? Maybe the patient was given Lasix. The patient is coming back with lethargy, found to have hypovolemia, and patient was hypotensive, probably from the Lasix that he got. So sometimes changes in medications might affect the diagnosis. So that's why do proper chart review to the prior to admission visits, including ED encounters or hospitalizations. But then the current visit, why is this patient here? What brought them here? What did they do in the ED? What are the investigations that were done? What the type of management that were done there? And then get to know what's the current status the patient is currently at. And then you go to the patient directly. You have now a list of questions that you want to ask. You are already kind of eliminated most of the conditions. Let's say the patient is coming with acute hypoxic respiratory failure. So you have a long list of conditions, but the patient doesn't have leukocytosis, just X-ray doesn't show any concerns for pneumonia. So you're trying to rule out the differentials by just reviewing the chart. Now you have a list of extra questions that you'd like to ask the patient. Maybe the patient aspirated has a pneumonitis, it's not showing on X-ray. The patient doesn't have leukocytosis, it's a pneumonitis from aspiration. So you want to ask them about choking, you want to ask them about coughing after eating. So that's how you build your questions before seeing the patient, and it will be directed towards the presentation. So during the rounding, take history, proper physical examination, and then you would think about the investigations that you would like to add on the top of the investigations that were done in the ED. And then after rounding, you sit down with your attending and you'll be running the list. And this is where Obada talked about arrange your thoughts, arrange your ideas before precepting, because the attending would expect you to do like a one-liner. Why is this patient here? What has been done so far? And what are we going to do in terms of your suggestion? Again, you might not be able to build like a clear plan, but you have a senior who would be able to guide you through the process. So before running the list, make sure that you talk to your senior and ask them about each patient, what are we going to do for them? And then, of course, share your thoughts. Like, I think this patient will be doing the following. What do you think? And then they will add to your knowledge. And then interpretation of the findings, and finally the documentation, which is the part that I'll be talking about. Now, I think Bakr already talked about this. There's no need for me to go over it again, but prior to admission, you go to any like office visits here, prior ED visits, and just review them, know why the patient was in the hospital or the clinic. And then the current ED encounter, why is this patient here? History presenting illness, and there is like a whole note about it from Dr. Urgent. And of course, Bakr talked about this. There is a summary, chart review, notes. Notes is for the patient's current encounter. So this is the ED note from one of the nurses who was in the ED who saw the patient in this current encounter. And then these are the lab work that were done to the patient. We talked about rounding, and then after rounding, we talked about a place. Once you're done discussing, you would place orders, call for consults, do some discharges, and then you would start working on your notes, kind of the last thing that you would be focusing on. So far, any questions you guys have? And if not, I can keep moving. Okay, so we can go to the next part of this presentation. It's going to be about documentation. Now, we have to know why are we documenting in order to build on how to document, what to add in your note. So in terms of the reasons behind our documentation, there are plenty of reasons. I'm just going to mention a couple of them. First of all, you know that you are not the only person who's taking care of the patient. There are other team members like nurses, other staff members, consult services, PT, social work. They want to know more about the patient. So they go to and reference your note. So your note is going to be the primary note that they're going to go back to and read. So make sure that you're writing all the information that you have collected and things that you have done. And then also the nighttime and the night team will be taking over your patients. So they want to make sure that they know everything that was done to the patient during the day. And that's why they go back to your note. Or maybe the patient might deteriorate. They will go to the medical ICU. They want to have a reference. And then the medical legal protection, of course, if it's not documented, it did not happen. Maybe you went to talk to the patient about a medication and you discussed the risk and benefits. The patient was willing to take the risk of refusing the medication, and then patient deteriorated because of that refusal. You did not document it in your chart. Whatever happens, it was not documented, so it did not happen. So make sure that you're writing every single thing that you have been doing with the patient. So it protects you legally. And then billing reimbursement, that's something that you guys don't need to be concerned about. It's going to be for the attendings. And finally, the communication. Make sure that you are closing the loop. You have all the documentation there. All the team members are on board. And also, it's important for the handoff. When the people are reading the handoff, if they have any questions, they will go back and reference to your notes. Now, how to document? Again, there are different systems, and even within the systems, the hospitals have their own kind of templates. So Epic is the most commonly used system here in the US. We have Cerner, Meditech, Allscripts, VA system. So there are different systems that here in the US is being used. In our hospital, we use Epic. And again, even within Epic, different hospitals have different templates for their notes. Now, we're going to start. So there are three most commonly written notes for you as residents you will be doing: the HMP and progress and discharge. For each patient, they're going to have the first HMP, and then they're going to have the progress notes done, and finally the discharge summary. So one discharge, one HMP, in between progress based on the days of their length of stay. There are consult notes. When you're on consult service or when you're on elective, you'll be doing them. That's something that I'm not going to be discussing here. There are transfer notes. There are also significant event notes. Different hospitals, different templates. I don't think that it would be worth going through them here. Now, in terms of the HMP, it's kind of universal. We know that we have to talk about the chief complaint, exactly what the patient says. Let's say the patient says, I have abdominal pain or belly pain, then you write belly pain. And then you have to start with a one-liner. What's the patient's past medical history? Past medical history of hypertension, hyperlipidemia, type 2 diabetes. Also, the patient had sigmoid diverticulosis in a prior colonoscopy that was done in 2017, let's say. And then who presented to the hospital with a complaint of abdominal pain. And then you go to the history of presenting illness. This is the mnemonic that we used to use in our medical school. I'm not sure which mnemonic you guys use, but it's very helpful. So kind of S stands for site, O for onset, C for character, R for radiation, A associated symptoms, T time and duration, E for exacerbation, and then S for severity. So again, patient had left lower quadrant abdominal pain, started yesterday evening as a vague abdominal pain, then progressed to be more localized, continuously present, progressively worsening, sharp in nature, stabbing in nature. It's localized, doesn't radiate to anywhere else. And then the pain scale, 8 out of 10 on a pain scale. The patient used Tylenol and ibuprofen that alleviated the pain. Pressing or moving around that worsens the pain. It's associated with fever, chills, diarrhea, dysuria, and these are the associated symptoms. And then patient denied relevant things like prior history of similar presentation. Is it the first episode of diverticulitis, if we're thinking about it, or is it a recurrence? And then Are there any associated symptoms like nausea, vomiting? Does the patient have small bowel obstruction? Any recent travel? Eating from outside? Any recent antibiotic use? Is it C. diff? And then patient had dysuria, also these things that we have to rule out, which is urinary tract infection. You'd ask about frequency, urgency, nocturia. And then if you're concerned about sepsis and peritonitis, you can ask about lightheadedness, palpitation, chest pain, or shortness of breath. These are kind of relevant associated symptoms. You have the review of system. Even for the review of system, I would be concise and focused based on the patient's presentation. I wouldn't just go over like all the systems, which might take a lot of time, and the patient might say yes for every single thing. You'll ask them about headache, they will say yes. You'll ask them about the blurry vision, they will say yes. But then when you dig deeper, that's kind of a chronic blurry vision that they have. They have been using eyeglasses for it. And then as part of the HMP, you have to take proper past medical history, any recent hospitalizations, any chronic conditions that we have to address in their current hospitalization. Past surgical history to get to know that. Medications, this is where we do the medication reconciliation. Some hospitals, the pharmacists do it instead of the residents. For us, we still ask about them. Different teams, we have pharmacists on different teams. Allergy list, you have to ask about it. Family history might be relevant. Patient had a history of colon cancer, let's say, or a family history of colon cancer. Then there's a concern that they are currently having a colon cancer. That should be on the differentials. And then finally, social history. In my opinion, on floors, one of the most important aspects is the social history of the patient, because you're not only going to help the patient themselves, but also multiple team members. So you're going to help the social worker, you're going to help the physical therapist, the occupational therapist, the dietitian in guiding the patient's treatment. Of course, they're going to ask about these things again with the patient, but you can help just collect the preliminary information for them. So living situation, did they come from home, assisted living facility, or a nursing facility? Because that's also going to determine their discharge. Daily living activity. Who takes care of them, or daily chores? Who does that for them? Do they do it for themselves, or someone else help them with it? So that would help the physical therapist and the occupational therapist in determining what should they bring with them to the patient. And of course, exercise is also relevant to physical therapist. The diet, is the patient on puree diet, mechanical soft, or regular diet? It matters, right? So this is where the dietitian and the speech therapist will use this information that you obtained. And then for the exercise and ambulation, you ask, are they independent? Do they use a cane or a walker? Finally, smoking. If the patient is a heavy smoker, you have to counsel them, and also you can help them with alleviating the symptoms of withdrawal from nicotine, so you can give them nicotine patch. If the patient binge drinks, so you can put them on a protocol called CEWA protocol to prevent alcohol withdrawal symptoms. If they use an illicit drug, so you can watch them from withdrawal from opioids, let's say. And then also you have to check if the patient uses home oxygen. Let's say they are using 2 liters of home oxygen. They're coming here, they're still on 2 liters. You would be concerned if this is a new oxygen requirement. Okay, maybe there's a pneumonia, a flash pulmonary edema, but it might be their home dose of O2 and they are just coming back. They're still at baseline, so it's not concerning. It's something that has been running for a while, you know. And then CPAP use. Do we need to use it or not? Does the patient use it or not? Because if the patient was using it at home and then they come to the hospital, you're unaware if they've been using it, you're doing a disservice to the patient. You're not giving them the things that they use at home. And this is an example of our note template that we have. Chief complaint, you add the information. History of presenting illness, you add the information that's related to the history of presenting illness. Now, in my opinion, I think past medical history, past surgical history, medication list, allergy, family history, they shouldn't be in this part. They should be after the review of system, or between the history of presenting illness and the review of system, but it shouldn't be under the HPI. This is the template that we have been using. And then social history, ED course, that's something that I also add in under the history of presenting illness. I want to try to summarize what happened in the ED, what the ED provider did, how the patient presented, hemodynamically stable, what were the lab findings that were relevant, was the patient febrile or not, leukocytosis, was there any bandemia or left shift, what were the electrolytes, were they within normal limit or not. And then the imaging, CT scan, showing fat stranding, suggestive of diverticulitis, let's say here. So that's why the patient was admitted. And then review of system, physical examination findings. This is part of kind of, you can say it's like a smart phrase or smart link that you click on it and then it auto populates. So it's easier to use as compared to you documenting it from the scratch. And then it comes the assessment and plan. For me, the way that I divide my assessment and plan, and you guys can follow it or follow the way that the hospital does it, but I start with a one-liner, like what's the patient's past medical history that's relevant, and why is the patient here in the hospital, and what are we treating them for based on my working diagnosis. So here we already reached a diagnosis of acute diverticulitis based on the CT imaging. So this is what I would write as a one-liner. And then I would address the problem list. Problem list, acute uncomplicated diverticulitis. You can add abdominal pain underneath this one. And then you write down what are the findings that go with this diagnosis. So the patient had a history of sigmoid diverticulosis and colonoscopy that was done in 2017. Coming now with left lower quadrant abdominal pain that's sharp in nature, associated with fever, chills, diarrhea, and dysuria. So there is a concern of likely acute diverticulitis. We got the CT scan, which confirms our diagnosis. The patient is currently hemodynamically stable. We are going to there are no signs and symptoms of perforation or sepsis. And then you put your plan. What do you want to do? And then the plan can be either the current things that I'm doing or things that I'll be doing in the outpatient, any referrals to GI, let's say, for colonoscopy, or what are like the FYIs. If the patient's condition deteriorate or get worse, then please do the following. So here the current plan is we're going to keep the patient MPO, and then we're going to start IV fluids. Again, this is not necessary to be scientifically correct, but I'm just saying. Begin IV Zosyn. You can treat with Tylenol, avoid NSAIDs, and then serial abdominal examination just to monitor for signs of worsening, like perforation or abscess. Stool charting to monitor the diarrhea. Is it progressing? Is the patient getting constipated instead? Repeat CT if any improvement. So this is the FYI. In case things are getting worse, please repeat CT scan. And then our plan in the future will be to transition this patient from IV antibiotic to oral antibiotic. So you can still share your thoughts. And then you write down colonoscopy, for example, for this patient, you want to rule out colon cancer. Now, one thing that would be missing in this note is to add further information about the differential diagnoses. So after you're done with this section, I would add other differential diagnoses would include, for example, kidney stone, renal colic, small bowel obstruction. So we'd write that down here. And if you have any reason to exclude them, you can mention why you're excluding, like why are they less likely. So that's how thorough you can get in your notes, and would be very helpful. So this is for the acute problems. And then comes the chronic conditions. Here we have, for example, hypertension. The patient takes these medications. So is the patient septic? Am I concerned? So should I hold these medications or not? You can determine that here. Hyperlipidemia, patient is on Lipitor, just resume it. Type 2, maybe the patient has elevated LFTs. So you would say, I'm going to hold off on Lipitor. I'm not going to start it. Type 2 diabetes patient is on metformin. Generally, we don't resume metformin in the hospital setting, so we will hold it to avoid lactic acidosis and other, it's going to remain lingering in the system. So we use regular insulin sliding scale. If the patient is MPO, if the patient is eating, we'll use Lispro. So this is what you're documenting here. And then the most important part also in any hospitalization is the disposition. All patients who are being admitted, our target is to discharge them safely. So part of the disposition, you would write what are the medical barriers and what are the social barriers. And that's what I wrote here. So once the patient is tolerating our diet, having bowel movements, patient is on oral antibiotic, then the patient will be medically ready for discharge. But then we still have the PT, OT evaluation. We have the social work evaluation for the patient to be safe, socially to be discharged. And then there are some other things that we add here. DVT prophylaxis, if the patient is MPO or should be on a diet, the code status, and then if there's any need for monitoring and the activity status. That's something that we add in our notes too. So this is for an HMP note. Any question about it? Okay, we can go next to the progress note. So the progress note style is different. We follow the SOAP style, which is the subjective, objective, assessment, and plan, as what Obada and Bakr talked about. Again, subjective, what I do is I mentioned about any acute overnight events that happened. For example, this patient, nothing has happened. No fever, no chills, nothing happened overnight. But let's say the patient spiked fever and that was addressed. I would talk about it. The patient had an episode of fever, maybe given Tylenol, or maybe was septic, given an septic bolus of fluids. So I would write that down here. And then I would talk about today's symptoms and complaints, and it should be subjective again, what the patient reports. So persistent but improving left lower quadrant abdominal pain. Now it's rating 4 to 5 out of 10 from 8 out of 10. So I'm just mentioning the improvement in the symptoms. No nausea, vomiting, fevers, or chills. These things has resolved. No bowel movements for today. So no diarrhea. We can't say constipation in one day. That's not a way to diagnose it. And then patient has been passing gas, which is a good sign. No urinary symptoms. So this is how you wrap up all the relevant subjective to this patient. And then review of system, you fill it out. We go to the objective part, which includes the physical examination findings, the lab results, and the CT imaging. And the same thing for the assessment and plan. The one-liner is kind of the same. Then the diagnosis, we have already reached to the conclusion that this is a diagnosis that the patient has. And then you try to modify on your note. Again, we don't recommend to copy and paste your note. If someone discovers it's not going to be a good thing, especially when you copy and paste, you're at risk of having a lot of mistakes. So it's preferable not to do it. Just start writing the note from top to bottom. You can use Dragon. You can dictate it. It's going to be as thorough as you can. And then also you can read your note. You can modify it while you're dictating. So here we're starting oral intake, advancing the diet as tolerated. You can see the plan here as what we're going to be following. Now, this is the SOAP progress note, and we're going to keep writing it on daily basis to monitor the patient's progress until we reach out to the final note, which is the discharge summary. Now it's time to discharge the patient. Patient is medically ready. Patient is socially ready. She's going back home. She did well with physical therapy. Medically, she's improving. She's now on oral antibiotic. She's tolerating diet, having bowel movement. So in our note, the discharge summary that we follow, this is the template. But I'm not sure. I think different hospitals have different templates. You can see here the reason and outcome of hospitalization. What's the reason? Acute diverticulitis. Outcome, it's resolved. And then change in the chronic medications, no changes, or maybe we held the antihypertensive medication, so you would write it down there for the PCP to follow up on it. And then follow-up issues for PCP. Make sure that the patient is advancing their diet well. Patient is undergoing colonoscopy in 6 to 8 weeks from discharge to rule out colon cancer. Some imaging, you list them down there. And then the hospital course, you mentioned about like the hospital summary kind of thing, like what happened and what did you do? What are the, for example, upon discharge, we resumed home metformin here. Of course, there's the interval history, kind of the subjective part, and then objective part here. Any questions regarding the documentation? Again, there are different types of notes that you guys will be writing, like consult notes, care transfer notes from the medical ICU to the floors. There will be the medical ICU notes. They are kind of similar to the floor notes. There's the admission note and then the progress note, and the transfer note is not going to be a discharge from the ICU. And then there's the outpatient notes that are like a new patient, kind of new patient visit or encounter. And then there are follow-ups for these patients. So there are different notes, different templates being used by different hospitals, but they all have the same idea: HMP, progress, subjective, objective parts, and then assessment and plan. We can go next. Now, once you're done with your notes, it's time to leave. In order to do it safely, you have to hand off your patients to the next team, either the long call team or the night team. So what's a handoff or sign out? It's basically a documentation or a summary about all of your patients in a concise way, and also you want to deliver a specific message. انت بدك توصل الفكرة إنه like أنا هذا patient, these are the things that I'm concerned about. They might happen over the night, and these are the follow-ups that I want you to check on at these times. And these are the consult notes that I haven't had a chance to follow on. The notes are not dropped in the chart yet. So if you don't mind following them up. So this is how we do and this is why we do the handoff. And why is it important? Of course, make sure that you're doing your best for your patients. And then effective communication, maybe the patient is undergoing a procedure, they're coming out, they need to resume their diet. I'm sorry. So you have to make sure that you're kind of signing that off to the night team, so they make sure that these, like the diet order is in for the patient to eat. And then we can go next. Where do we do the handoffs? Generally, we do it mainly in the floors and the ICU setting. We don't do it in the clinic. For the clinic, you guys can read the note and know what happened in the prior clinic visits. The type of, like how to do the handoff. For us, what we follow is the IPASS. I'm not sure about other hospitals, what they do, but for us, we do the IPASS. The I stands for illness severity. What's the patient's current illness severity? Is it stable? Are they stable, intermediate, or high risk? They are at risk of deteriorating. And then a brief patient summary. You don't want to see the whole HMP written in that, like the patient summary. You have to be concise. If something happens overnight, you can imagine yourself as an overnight resident, and then something happens and you open the handoff and you read like a very long note. You'll be like, this is not an HMP. It's just a brief summary. I want to know, why is this patient here? What are we doing? And what are the FYRs or action lists that I have to keep in mind? And then A stands for action list, things to do. Like, please follow up on that consult. Please follow up on the blood work that we did. We did BMP. Make sure that you replace potassium. And we're going to talk more about the action list because there are more details to it. And then situation awareness, FYIs. This patient doesn't have the capacity to leave the hospital. This patient is at risk for opioid use disorder. So be careful when you're giving opioids. This patient has drug-seeking behavior, let's say. So there are other kind of situations that you can FYI your team. This patient is going to be MPO after midnight, so that you get paged at 3 a.m. The patient is asking for food. You can't go there and tell them that you are MPO after midnight because of the procedure that you'll be undergoing. It's kind of a reminder for them. And then the final S is a synthesis by the receiver, kind of closing the loop. Again, illness severity, we talked about it. Stable, intermediate, or sick. If the patient is sick, as an intern, I would go to the senior, make sure that I'm signing it off to the senior and the junior. Both of them are on board in case something happens. And of course, try to include the code status, because that would help. If the patient codes and they are DNR, you don't want them to be resuscitated, right? And then the P, patient summary. Concise, one-liner. Why are they in the hospital? And very brief, pertinent events regarding the plan of care. If the patient had the procedure or they are on antibiotics. So this is an example we have. 55-year-old man with a past medical history of HFpEF, admitted for a volume overload, currently being aggressively diarrheased on Lasix strip. So now the overnight residents would know that this is the most pertinent part. There might be other conditions. Maybe we're treating also for pneumonia. I would also add the antibiotic there if we're also concerned about pneumonia. And that's it. You don't need to add further information. That's irrelevant. Then the action list. You have to be specific. Again, the long call team, they have a list of 50 patients or 60 patients. They can't know every single small detail, or you can't give them like an open action list, like follow up BMP, and that's it. Now you have to be specific, what to follow and when to follow, what to do with the results. So follow up BMP at 6 p.m. So they will open the chart at 6 p.m., check if the BMP is reported, if not at 7 p.m. So they will keep a close eye on it at 6 p.m. And then what to do? Let's say the potassium is 3.5, should I replace or not? The potassium is 3.7, should I replace or not? So you would specify the cutoff. Maybe this patient is being actively diarrheased, you're targeting a higher limit of potassium and magnesium. And you can see that here. So follow up at 6 p.m. BMP for K and magnesium. You don't need to mention while aggressively diuresis, but you can mention that keep K more than 4 and magnesium more than 1.8. Sometimes they say, don't give the patient opioid. Please give me the alternative. You can't tell me don't do something and then leave me hanging without an alternative. Don't give this patient Haldol. Okay, give me an alternative to that. Maybe go and reorient the patient yourself. So you go and talk to the patient, reorient them, and then come back. You don't need to give the Haldol per se. Situation awareness. Maybe there are some behavioral concerns. how to manage pain or potential risk of decompensation. So you would FYI the team. So here, for example, we have an example here. Patient may request pain medications. Please assess the patient first. Try to avoid IV narcotics. You can use low-dose PO oxycodone if necessary. This is something that the day team already discussed with the attending. They agreed on. They're just signing it off to you. You were not there in the morning. You don't know what happened as a conversation. For you, it would be easier to give IV opioids, but maybe the patient has some drug-seeking behavior, so you don't want to enrich that, right? Synthesis by the receiver. So make sure that there's a closed-loop communication. It's time and opportunity for the night team to ask questions and to confirm their understanding. And if you're not sure, make sure to clarify. It's your time to ask questions. And then make a habit of having your senior be there when you're taking the sign out, especially in the first half of the year. I wouldn't say the half of the year, maybe a couple of months, first 3 months. Make sure that the senior is there, take the sign out. If you have any concerns, ask your senior. So whenever you get paged for anything overnight, make sure you go, assess the patient, and document. If you don't document, it didn't happen. So make sure that you document and write down all of what you have done. For me, I used to create a list of the things or the patients that I want to follow up on. So I'll drag these patients, put them in my 169, we call it, or long call list. And then would add all the patients there, follow up on them closely every hour or every 2 hours. And then be prepared for the sign out if there are any important events to happen. You might also go and assess a patient by yourself if you're concerned about one of them. Now, in terms of the ICU, medical or cardiac ICU sign-outs, it's kind of different, and you have to be more thorough. Sometimes you spend like up to 30 minutes to an hour just signing off the patients. Even if you have like 7 or 8 patients, it might take that long. Because we want to make sure that we're addressing the old patients first. We're telling the night team everything that we've done during the day, any discussions that happened with the attending, and let's say that there was a question about an antibiotic, they decided to take a different antibiotic, so we have to tell them why this happened. And then you talk about any active issues that happened either during the night or during the day. And then the urine output, we talk about it. Maybe the patient is in AKI, patient is getting pressors, they are at risk of having AKI, patient is getting fluid overloaded. So I want to talk about urine output, pressure requirements, any change in antibiotics, any change in the ventilator settings, any lab findings, and any expectations during the day. Maybe in the morning, you want to wean off the ventilator, you want to extubate the patient. So you have to give them that expectation. Any FYIs for the night team to be aware of. If there are any new admissions, you have to go thoroughly over them. Like if this patient is coming acute hypoxic respiratory failure, we're concerned about COPD, maybe community-acquired pneumonia. We're treating for the following. We're doing the following antibiotics. This is the VBG. These are the findings. This is the physical exam findings. So try to gather all the information, give it thoroughly in an arranged way for the new admissions. And always ask questions. This is your time, especially if you're covering the night. Ask questions. It's your time. Make sure that you know and clarify every single detail. And once you have everything clarified, then it would be good to go during the night without having any significant issues. Thank you so much, guys, for your time. Please feel free to ask any questions right now or reach out to me. Thank you.
Thank you so much, Anas. Great, very, very great presentation. I really enjoyed it.
Appreciate it.
I was like, having this much of exposure to لكل شيء محتاجينه was really great. So we can start actually
Thanks.
now receiving questions regarding the whole panel. Thank you, Obada, for sharing the slides. If you guys have any question, please feel free to open up your mic and طيب أنا عندي سؤال. Have you guys ever, experienced miscommunication happen during signing out or passing over to the next team, and how do you deal with it? I know it sounds like an interview question, but I actually, interested in knowing how you guys deal with such situations.
I'll let the residents answer, to be honest. And then you guys let me know.
طب I will share my experience يعني I can't think of specific situation but unfortunately this happens a lot. Sometimes sign-outs are not as prepared or as not given as structured مثل ما الدكتور أنس تفضل. فأوقات في معلومات it goes through the cracks. يعني مثلا sometimes sign-out may not include the pertinent details that you need to be aware of. فيعني the way you manage this if it happens one time we all make mistakes so عادي يعني you just make sure to fix the problem and move on. But if this is something that happens repeatedly, you might want to bring this up to your chiefs. They might have to speak with that specific resident to maybe understand why they are not giving proper sign out, or maybe the whole structure of sign out in the program needs to be readdressed. بس يعني I think this is the way I would approach it. أنا عم بحكي تذكرت وقت كنا interns السنة الماضية في أحد ال PGY3s اللي هو was leading sign out. He went into نحن كنا نعمل sign outs في team rooms. Went into one team room and asked any updates I need to be aware of, anything that any patients dying, and the other senior told him no, so he left. That was inappropriate, and for some reason he did not notice that an attending was sitting outside the room and he heard this. Of course he got in trouble, in a big trouble, and then they had to restructure the sign out and make sure it's done all the teams in one room and there's attending available and it's done in a proper way. So yeah, it happens, but just keep an eye on repeated pattern and escalate to your chiefs if this happens.
I can share one incident. Like there was a patient who had a gastric ulcer, and it was like a bit of a big gastric ulcer. And the GI team did an endoscopy, and they said, like, please do not replace the NG tube. They placed the NG tube under like endoscopic guidance. So they said, please do not replace the NG tube if the patient pulls it out. And that was only written like in one line in the GI notes. It wasn't documented in the primary team's note, and it wasn't documented in the sign out. So what happened is that the night team, they got paged for the patient, pulled out the NG tube, please go and assess or replace it. They want to give the medications for the patient. So they went to the patient's room, they read the sign out, they said the patient's note, the primary team's note, and they didn't see anything that's related to NG tube, so they decided to reinsert the NG tube themselves. Thankfully, nothing happened to the patient. It's kind of like a near miss, but if something had happened, it would be a big deal. Patient might perforate, have peritonitis, end up in the OR.
Okay. We have a question from the chat. If the program is new, do you have any advice, any other advice, especially like regarding missing senior residents?
I didn't get the missing senior resident part.
I guess that the program is newly accredited.
Oh, you
and they
mean
don't
you mean
have
like they are the first batch? Oh, okay, I get it. That's tough. I mean, I have no clue, to be honest, but I would do my due diligence, to be honest, because I'm going to be the first line. There is no senior above me, but I'm going to make sure if I have any questions, I would reach out to the attending, because they're going to be the link, or the chiefs, if there are any. Sometimes these programs, they recruit chiefs from outside. They don't have any residents, like internal residents, to recruit them as chiefs. They will get chiefs from outside, so you can reach out to them for any concerns. And I would escalate any things, especially since you don't have a senior to ask for help. But I don't know who's going to guide you in the notes. I think it might be a bit more difficult. I would put more effort in order to combat this.
I just have a comment on this topic. Whether you have seniors or you don't have seniors, don't feel afraid of escalating to your attending or to your seniors if you have any questions. The way the residency structured is for you to have support. And even if you feel like it's a stupid question, no questions are stupid. Don't feel any burden that don't feel that you're going to be burdened on the senior or on the attending. You're going to ask them. Just ask as many questions as you have to, and this is the way you're going to learn. This is the way you're going to go through the system, understand the workflow, and learn how to manage patients.
Okay. If there's no other question, I have another question. I know, we really limited Bakr's time talking about Epic and EMRs. But this is a question for all of you guys. I've heard like there are sometimes people recommending like is like special cases. I guess like Danny also talked about this. Like before starting even your internship, try to save the most interesting cases that you could have used later on for writing case reports or for any kind of research. Do you have any similar strategic, tips and tricks for new Epic users? Like for in such matter, like شيء مثل هيك انه يكون بخص early planning.
Actually, I have Epic, the hyperspace training environment open. I can show it to you, like what I used to do.
Yeah.
So
Please.
let me share my screen. So for me, it's just very simple. I would create a list here. I call it research case report. And then whenever there's an interesting case, just to save it, just drag it in, right? That's it.
Okay.
Straightforward. And then you go open and then you'll see all the list of the patients that you're interested in. Again, these are not real patients.
Mm-hmm. Mm-hmm. Anything
these are the lists that I have. It's kind of the list that I have, like floor lists, ICU lists, all patient lists, like everything in all the patients in the hospital, my cardiac patients, anything interesting, and then case reports.
Same goes for PowerChart. It's pretty straightforward. You can create a list, label that as research, interesting cases, or whatever, and it's really easy to move patients or add them to the list. So it should be available to any EMR you're going to be using.
Any other recommendations other than for research purposes to save cases? Would you save other cases for other reasons than research?
Yeah. These are my patient list. Of course, you're not going to see the patients, but there are some interesting cases that I wanted to follow up on. They got tested for something, and let's say a genetic test or like a send out test. I'm just waiting for the result, and it might take a while. So just keep them there. Or some patients who I want to, like, let's say I treated them, and because I'm currently working as a hospitalist, so I want to chase like what happened with them in the future, what's going to happen, and I'm interested to know, are they going to be readmitted or not? So just put them there to monitor their progress.
I will add something to this. So we, as a PGY2 in our program, I was expected to give morning reports after night shift. So whenever I have a somewhat interesting case, does not have to be interesting enough to be published, or it does not have to be interesting enough to be written as an abstract or manuscript, but somewhat interesting case, I want to share it with the interns, I want to share it with my co-resident, I would add it to a separate list. Also, I'm expected to give a lecture on patient safety, M&M, morbidity and mortality. So whenever I have the patient that there was some patient safety concern, there was some near miss or some error happened, I would add them to a separate list. In the future, I might need it, so I will have these documented.
Yeah. شكرا كثير. Christine, please go ahead and open your mic.
Hi, everyone. Thank you so much for sharing your experiences. It's been a very helpful talk. I have a question. So, let's say, like, how should we behave if we disagreed with our senior on the management of one of our patients? Let's say we refer to UpToDate and it suggested a different management plan. How can we confront our senior resident with this and at the same time be professional but not be rude? I don't know if you guys ever encountered that.
I can take that.
Yeah, please go
So,
ahead.
I'm gonna speak from an intern perspective because I'm finishing up my intern year. So it depends on the situation. Like if it's something that's really, simple, that, it's like very simple management of something that's really simple. Like for example, you want to do this muscle relaxant instead of that muscle relaxant extra, you don't really have to bring this up. But if it's something that you know for sure and you have your evidence that this is gonna affect the patient in a bad way, yes, you have to discuss it with your senior. You have to tell him about or her about your evidence, and also sometimes, or most of the times actually, seniors will be very receptive actually, because they're going to be like second years. It's not that much of a difference. But you will face people, or you will encounter with people who are I would say egoish a little bit. So that's in every single place. So in that situation, they will hold to their opinion about the management. However, at that time, if you're sure about your opinion, about your evidence, so you can pull the attending in the discussion. So and you can have like a team discussion with everyone. The main goal for you is to treat your patient. So, but again, you do all of this with professionalism. You should pay attention for your tone of voice. You should pay attention for the wordings that you're choosing. You should pay attention for the evidence you're providing. You cannot just say like, "Oh, I read somewhere on Facebook from this physician that he was doing this." This is not something that you, as an intern, you should be kind of building your evidence on. You say like UpToDate, you say MGH, you say PubMed, etc., etc. You say like ACC guidelines, you say NCCN guidelines, you say, you know what I'm talking about.
Okay, great. Thank you, Dr. Bakr.
I can give my input from senior standpoint. I agree with all what Bakr said. It's expected, all seniors should expect that they might have some disagreement in the plan with interns. And again, this is residency. This is the way it's structured. It's open conversation. So don't feel afraid to disagree with your senior. But as Bakr mentioned, as long as you do this in a professional manner, it's not going to be a problem. We had an intern he's an IMG. ما شاء الله عليه. هو يعني he's working on a level of 30. الميديكال knowledge تبعه يعني أشطر من الانترنز ومن السكند years يعني ما شاء الله عليه. هو كان almost cardiologist at his home country. ففي البداية كان التون تبعه لما يختلف مع السينيور يكون فيها شوية intensity. فالبروجرام عطاه فيدباك عن الموضوع، ومع الوقت هو حسن التون تبعه، صاروا السينيورز يتعلموا منه لانه هو يعني اوريدي عنده اكسبيرينس. فهي الفكره مثل ما حكى بكر بالتون professionalism و don't feel afraid to bring up your concerns.
Great. Thank you so much, Dr. Obada.
I have other question regarding documentation. How did you guys write your first note, and what you can do to keep improving? Is there a way that I know we probably, I mean, I haven't done that yet, but like probably later on أكيد حبلش بشيء سيء وحيتحسن بعدين مع الوقت. شو الشيء اللي عملتوه لحتى صار يتحسن بشكل أكتر؟
So I'm gonna again start from my perspective internship. I'm still getting dinged about a lot of stuff in my notes. Don't do autopilot. That's the only thing that I have to tell you. Do not autopilot. What I mean by autopiloting is like whenever you're trying to write your note, be mindful of what you're writing and be mindful of what's happening. You know, a lot of people, like for physical exam, you know, the patient is intubated and sedated. The patient has been extubated for the past 10 days. Okay, so you know, don't just write your note to finish your work. Write your note because this is something that people will read, you know, and it's a habit. If you start doing this with autopiloting, whenever you are a private practitioner or something like that, physician, like independent physician, that's gonna stick with you. So either it's a bad, if it's a bad thing or a good thing. So do not autopilot. Try to be mindful. That's the only advice I have.
على سيرة الاوتو بايلوت is just funny story. وقت بلشنا ريزنسي في كو انترن بالغلط عمل اوتو بايلوت لفيزيكال ثيرابيست نوت و sign it to the attending. ف يعني ما كان حدا عرفان. He did not have senior that day. It was a weekend. So we always joke about it. Don't autopilot, as Bakr mentioned. My first HMP took me 3 hours. I left the hospital 7 p.m. Although senior was really helpful, but يعني it's expected for you to struggle for when you write your first few notes. بس يعني it's just trust the process. Ask for feedback about your notes. Attendings عنا كانوا يقولون إنه print your HMP or print your progress note and show it to me, and I will tell you what did you write, what did you do right, and what did you do wrong. You can ask your seniors also to give you some feedback. Just do it over and over, get feedback, try again, and by I think August, maybe September, you would be able to write your note efficiently, and probably by the end of your intern year, if you continue with the same pattern, you'll be able to write perfect notes.
Just one, sorry, Dr. Hashem. Sorry, just one more thing to add. So basically, لما عم تكتب الاسسمنت plan, it's gonna be different in every single hospital. يعني بيدخل عندك البيلينج purposes، بيدخل عندك الاي سي دي codes، بيدخل عندك كل القصص هي، كل القصص هي بتتعلمها يعني اثناء الشغل. بس الثوت بروسيس تبعك لازم تكون محطوطه بالاسسمنت بلان. يعني صح انت مثلا انه بتحط مثلا انه acute hypoxic respiratory failure بتحطها اسسمنت، والبلان تبعك انه مثلا ريتشيك تشست اكس راي مثلا continue oxygen supplements الى اخره، تمام. بس انت you have to put your thought process لانه الناس عم تقرا النوت تبعك، عرفت؟ يعني انت مثلا تحط this is likely because of acute heart failure exacerbation, acute exacerbation of COPD versus other etiologies الى اخره، تمام. الانفكشن مثلا انت ليش مثلا اخترت هذا الانتيبيوتيك ما اخترت الانتيبيوتيك الثاني؟ مثلا انت مثلا اخترت ميروبينيم لانه هذا المريض مثلا عنده history of ESBL مثلا على سبيل المثال. فانت حط الثوت بروسيس بالاسسمنت تبعك، لانه هذا الشيء بيبين انه انت ببين النولج تبعك، وهذا الشيء بنبنى مع الوقت. يعني انا مثل ما قال عباده الفيرست اتش ام بي انا اخذت معي 3 ساعات كمان. انا طلعت ما بنساها، طلعت من المشفى الساعه 9:30 بالليل. بس كانت اول حاله اجتني كانت اكيوت بنكرياتايتس. فانت بدك تحط المانجمنت بلان تبعك بشكل يكون مرتب ويورجي انت شو عم تفكر، يورجي انه انت المانجمنت بلان بعقلك شلون موجوده. تمام. هلا بعدين بعد وقت بتصير كمان تختصر هون من هون ومن هون ومن هون، بس لازم تتم هي الفكره موجوده. وكمان راح تشوف كثير اختلافات بالنوتس بين الدكاتره، وهذا بيقول لك هي النصيحه وهذا بيقول لك هذيك النصيحه ومدري شو. امشي مع بالنص، يعني امشي بشكل متوازن. يعني في ناس تقول لك مثلا اكتب هي، في ناس تقول لك ما تكتب هي، في ناس تقول لك اعمل هيك، في ناس تقول لك تساوي هيك. يعني راح تسمع كثير من هون ومن هون ومن هون. بالنهايه بدك ترجع لشو سيستم المشفى بده وشو الشيء اللي راح يطورك لبعدين.
هلا انا agree with you guys. انا نفس الشيء صار معي باول بتذكر اول ريزيدنسي. thankfully احنا البروجرام تبعنا so supportive، يعني 2 residents بيكونوا بس على 10 patients، فالسينيور takes care of most of the patients، بس بيعطيك مثلا 1 progress 1 HMP و let you go. وبالفعل يعني كنا نتاخر نخلص مثلا الساعه 6، احيانا نوصل للساين اوت، نحن نعمل ساين اوت للنايت تيم ما نعطيه لللونج كول، فيعني نوصل لهالدرجه باول كم يوم، حتى ممكن اول اسبوع او اسبوعين. فit's a normal process. We are all gonna go through. We went through it. You guys are gonna go through it. بس إن شاء الله you're gonna develop. هلا كمان ال residents they end up in a spectrum. Some of them يعني حتى لهلا نحن عندنا مثلا ناس PGY3 PGY2 they spend the whole day just writing notes. يعني بيكون كمان في component of efficiency. Sometimes they just want to add all their thought process، فبتصير في شيء اسمه I think بيسموها documentation overload. It's just like طبعا if I'm gonna read this note I'm gonna take a day لخلصها. طب انه this is not a NAJM journal. نحن عم نحكي على HMP. it's a note literally. يعني you have to take less than like 3-4 minutes خلص كل شيء. This is all what you need to get and that's it. بس لما تكتب لي a long note I think it's so distracting وبتضيع، يعني you're gonna get lost with the details. ف او في السبيكترم تاعي هو they copy paste وبضل مثل ما حكى بكر انه بيكون والله patient still they're saying intubated, patient already extubated is being discharged، بحطوه حتى discharge summary patient بيطلع intubated. فيعني just be mindful when you're writing your note. واجين يعني انت that's why I prefer dictation. انه انت بتقرا النوتة تبعتك البارحه you try to modify it in your brain وتصير بتحكي، ممكن تعمل شويه تعديلات ولا هي this has been changed. Now the patient is on a different antibiotic، فانت بتصير تعدل لانه انت you're being mindful. I think most of the residents will be in that spectrum. Majority will be in the middle where they're going to initially they're going to struggle, they're going to take their time، بس بعدين they're going to go back to the normal bill curve shape. رح يرجعوا كلهم بالنص، كله حيخلص on time وبيطلعوا الساعة 4:30. بس it's going to take, it's a process. Just be patient.
Okay, I don't know how much of you guys have time with us, but we have also the question regarding do we need to care about or deal with insurance companies regarding our management? By the way, sorry, before answering this question, if you guys feel that you need to leave, please feel free to leave.
I think when it comes to insurance companies, attendings deal with this more than residents, but unfortunately, there is still some component of having insurance in the back of our mind when we prescribe medications. For example, a patient came in with PE and we need to charge them on oral anticoagulation. This is really common and you're gonna all experience this. Some insurance companies will cover Aliquot, Apixaban, or some insurance companies won't. You may need to keep that in mind, send the script early on in the hospitalization to make sure it's covered or not, to make sure if there's prior authorization process. And then if not, you need to start, for example, warfarin, keep the patient additional few days to make sure that they are in therapeutic range of INR. So this is something that we deal with. Also, when it comes to discharge, in many cases, we discharge patients to ECF, extended care facilities, rehab centers, where insurance companies need to cover their stay over there. And sometimes we call it pending placement, where the patient is medically cleared for discharge. However, they're waiting for insurance to approve their discharge to a rehab facility. And unfortunately, sometimes the insurance may not approve the rehab, so we might have to come up with a different discharge plan. So sometimes it might be a headache dealing with all the social aspects of discharge and dealing with insurance. And that's why each hospital has a case manager, or what we call them patient care facilitator, where they help arranging the insurance communication. I think most hospitals do have these, but you need to keep up with all the updates. So there is some exposure of you dealing with the unfortunate situation of insurance companies.
For us, I think it varies from a program to a program. For us, in the outpatient setting, we work on prior authorization. We have to mention the ICD codes and do everything and then send it. Of course, the access associate will be sending the documents to the insurance companies, but we're kind of involved in the prior authorization process. For the inpatient setting, as you mentioned, like for example, Eliquis, you order it, it's so expensive, the patient is not willing to pay $600 for that medication. So you'll end up changing the medication, let's say to warfarin, because the insurance did not approve it. So I think regardless, wherever you go, there will be still some component of you being afraid of ordering a medication because it's not being covered, and then you're going through that process. Or sometimes an insulin there are two types of insulin, both of them are glargine, but they're different companies. One of them is approved, one of them is not. So you have to be mindful which one to order. So you are going to be in that situation with the insurance companies, but it might not be directly.
All right, great. Do we have any other questions? طيب تمام شكرا كتير. Thank you so much guys, it was really helpful. I personally enjoyed it a lot. Would be really needed to actually go back videos and نرجع نشوفهم again. So thank you for allowing us to post those on YouTube. Stay tuned for tomorrow. We have another busy day tomorrow morning inshallah. And also for the speakers, feel free, we have an open session starting tomorrow, I believe at 12. You guys have the schedule at 12:30. Will be an open session. If any speaker want to add anything up, will be more than welcome to do so. Thank you so much again, and have a good rest of the day. Bye.
Thank you so much, Hassan. Thank you. Take care.
Thank you.